Well, we still have 1 minute to spare, and I know Kathleen is coming as well, but just to make sure we start on time and finish on time as well, we can maybe do a round of introductions first to start things off. So everyone knows me, I've been in contact with you all, and perhaps we can start with Cynthia if you like.
Sure. Cynthia Stewart. I chair the NGO Committee on Aging in New York, and I'm also a board member of the IFA and the IFA's UN main representative.
My name is Dalia, Dr. Dalia Zindida. I'm a lecturer in public health at the University of Liverpool, UK. I'm doing research over the past 10 years in hearing loss from a social, epidemiological, and public health perspective. And I participate in the committee of World Hearing Forum of the World Health Organization.
My name is Nathawan Itongthupon, so I'm based here in Bangkok. So I'm the lecturer at the Faculty of Medicine, Chulalongkorn University, and my specialty is in hearing and balance. So I got my PhD from UCL in the UK about hearing loss, hearing prevention and treatment for MCI, older adult with dementia. I'm also the chief medical officer for Eartone, which is the local organization for medical health in Thailand taking care of hearings. So in Eartone, we got few grants from the Thai government and the UK government to develop a hearing technology, for example, the hearing screening application, the hearing rehabilitation application program for the Thai people and the neighboring countries.
Hi, I'm Tina Pillai. I'm a CTO of Eartone. I'm the one who do all the technical software developments, algorithm developments, and testing for all the grants and all the research projects that we're happening.
I'm Kathleen Brash from La Trobe University, and my work is with age-friendly cities and communities and age-friendly healthcare in small rural communities.
Thank you, and we do have virtual attendees as well, so if they would like to give a brief introduction, only if technology allows, we'd be happy for that. Dr. Kathy Fuller, first on our picture screen, if you'd like to introduce yourself.
Okay, I am an audiologist, and I have worked on the World Hearing Forum too, and in particular on the technical working group for screening in older adults. And I am a psychologist who studies communication and aging and sensory cognitive links, and I'm a gerontologist in Canada.
Thank you very much. And Dr. Kathleen Fuller.
I'm an audiologist, a professor of audiology at Macquarie University. I worked on the World Report on Hearing, the WHO report, and am a commissioner on the Lancet Commission for Hearing Loss. I also worked with Kathy and Shelley and others on the technical report for hearing screening for older adults.
Thank you very much. Next we have Dr. Arun Agarwal, if you'd like to introduce yourself.
Good morning. I'm Dr. Arun Agarwal from New Delhi, and very much associated for the cause of prevention of deafness and somewhat associated with WHO headquarters also, with Shelley.
Thank you very much. And Dr. Shelley Chatham.
Good morning. I'm Dr. Shelley Chatham from the World Health Organization, where I lead the work WHO does in the field of hearing care. Very pleased to be able to join you virtually today.
Thank you for joining. And then Dr. Leo Durab, if audio allows.
Sorry, I was just having a little bit of difficulty with the sound there. So I'm Chris Poulos. I'm a rehabilitation physician from Australia, work with a large not-for-profit aged care provider at the moment, and mainly involved in providing community-based rehabilitation and restorative care programs. And I'll be switching to different devices. So if I sort of suddenly disappear and reappear in That's because I have to switch through to a couple of devices throughout the meeting. Thanks.
Not a problem. Well, thank you all for joining. And again, this is being recorded in case anyone is not able to join due to some of the time difference challenges. But to get started with our presentation, so as an agenda of the way today will look like, we will start off with our opening remarks, and following that, we have some pre-recorded sessions from our key experts. Then we'll go into a health break and the second symposium. So firstly here, we have a opening remarks video with Dr. Shelley Chapman and Dr. Yuka Sumi from the WHO.
Hello, and greetings from the World Health Organization. I'm Shelley Chatta. I'm the technical lead for hearing care at the World Health Organization's headquarters, and with me is my colleague.
Hello, my name is Yuka Sumi. I'm responsible for integrated care for older people at Aging and Health Unit.
We would like to start with two key messages that we want to convey through this introduction to the symposia. Firstly, integrating hearing care into care of older people is essential for healthy aging. And secondly, such integration is possible, cost-effective, and would facilitate person-centered care. So first, I would like my colleague Yuka to speak on the first aspect. What is meant by healthy aging, and why is healthy hearing relevant for this?
Thank you, Sherry. WHO defines healthy aging is the process of developing and maintaining the functional ability that enables well-being in older age. Functional abilities support people to be and do what they like, including not just to meet their basic needs, but to learn, grow, and make decisions, be mobile, build and maintain relationships, and contribute to society. Functional ability is made up of the intrinsic capacity, which is physical and mental capacities of the individual, and environmental characteristics, including assistive products such as hearing aids and the interaction between environment and intrinsic capacity. Hearing is an essential domain of intrinsic capacity. We know that hearing is important to maintain communication, which is key for maintaining relationships, for learning, and social engagement. Moreover, if we don't address hearing loss, this is a common risk factor contributing to cognitive decline and dementia. So it is important that hearing loss to be identified and addressed at the earliest possible so people can maintain their functional ability.
Thanks, Yuka. And I would like to add to this that the need for integration of hearing care is highlighted by the fact that over 30% of people who are above the age of 60 years, they experience disabling levels of hearing loss. That is, levels for which they require intervention, rehabilitation, and support. And that the prevalence of disabling hearing loss, it rises rapidly during the last decades of life, rising from 15% amongst those who are 60 years old to over 50% amongst 80 years old. Moreover, because hearing loss is invisible, despite these statistics and the high impact that Yuka already outlined, people commonly wait as long as 7 to 10 years to get their hearing checked and to seek hearing aids. Even then, many of those who could benefit from a simple hearing aid do not have access to this device, either because it is not available or because it is out of their reach financially. And that's why integration of hearing care into healthcare of older people is essential, because without it, this status quo will not change. What do you think, Yuka?
Indeed, Shelley, that is the reason why WHO Integrated Care for Older People, ICOP guideline, recommends for hearing screening of older people, followed by provision of suitable hearing aids and rehabilitation for those who require them. WHO has also developed a simple-to-use app for assessment and management of intrinsic capacity as part of its work on implementing these recommendations. This ICOP handbook app links to an automated, easy-to-perform hearing app, Hear WHO. We really recommend you to download these two apps. As the world ages and countries transform their systems and develop strategies for healthy aging, it is important that they take a holistic view of health and integrate all aspects of intrinsic capacity, such as mobility, vitality, including nutrition, cognition, psychological well-being, eye health, and hearing health.
As you mentioned, Yuka, WHO already provides the guidelines and the tools that are required for integrating hearing care into care of older people. We also provide detailed technical guidance on how hearing screening can be done systematically in adults. But what I want to stress now is that such screening, it can be done not just in clinics and hospitals, it can be done even in people's homes and in community settings by trained non-specialists using apps such as the ones that Yuka mentioned. What's more, hearing screening, when it is followed by care, is cost-effective. And we estimate in the recently published World Report on Hearing that every dollar that is invested into systematic hearing screening in older adults can bring a return of over $1.6.
That's correct, Sherry. And that brings us back to the key message we developed in the beginning. It is essential to integrate ear and hearing care into care for older people. And it is possible to do so, and it is well cost effective. And this would facilitate the person-centered care. And now we look forward to hearing the speakers talk about why integrated hearing care is a must and how this can be achieved. Thank you very much.
Thank you, everyone.
Well, thank you, Dr. Yuka and Dr. Chapa for that opening remarks. Dr. Yuka Sumi is actually in another meeting currently, so she wasn't able to join, but Dr. Chapa is here, and if there's any additional things you would like to add prior to the symposium, we have to hear that as well. Dr. Chapa, is there a few words you'd like to share prior to moving along to the speaker presentations?
Thank you, Roxana, for the opportunity to speak again. I don't want to take too much time, simply to say that, to echo what we already said, that it's essential that hearing care be considered an integral part of care of older people. It's also possible. It's possible that we provide this integrated care to older people without adding a huge cost to it, as well as bringing returns to the society. And indeed, as Yuka said, it is integral to person-centered care, the person-centered care approach that we want to promote. And the starting point for hearing care as WHO is systematic, universal screening of older adults for hearing loss. So that is what we are pushing countries, what we are advocating with all organizations to adopt and to implement. That is systematic, universal screening for hearing loss in older adults as part of integrated care, along with rehabilitation services to address that hearing loss once it is detected. So with that, I would like to hand back to you and thank you for this opportunity.
Thank you very much. Moving along to the first symposium, we actually have Dr. Stewart and Dr. Pecora Fuller on why we must integrate hearing care into health systems. So without further ado, I'm actually going to play the video.
Well, good morning, good afternoon, and good evening to everyone joining both in person and virtually for the Hearing in Later Life Symposium at the IFA 16th Global Conference on Aging. My name is Roxana, Policy and Advocacy Program Lead at the International Federation on Aging, and I have the true honor and pleasure of introducing both Dr. Kathy Pecora Fuller and Dr. Cynthia Stewart on the topic of why we must integrate hearing care into health systems to start off the first of the two symposiums for the conference. Now I'm going to hand the floor over to you both, Kathy and Cynthia, and perhaps to start this discussion off, maybe I can ask you to share a little about your backgrounds and how your professional disciplines contribute to the recognition of hearing and other sensory impairments. Now, Kathy, is it okay if you can kickstart the conversation?
Okay, well, thanks for organizing this, Roxana. And it's fabulous to be able to have these conversations. And conversation is part of our everyday life. We take it for granted. But what would you do if you couldn't have a conversation? So that is, fundamentally such a central part in life is communicating. And my undergraduate training was in linguistics, and I studied languages and literature and enjoyed all of the richness of communication. And then I began to think about, well, what if people couldn't communicate? So my master's degree is in audiology and speech sciences. And I worked in a big teaching hospital in Toronto in an audiology clinic where we had very enlightened ear, nose, and throat doctors, and they sent us people who had problems with communicating and with hearing. And often these were late middle-aged executives from the financial district, people for whom miscommunications could cost them millions of dollars, let alone their marriage or their relationship with their children. And these people were in the early stages of hearing loss, and they didn't necessarily have enough loss of being able to detect sound to need a hearing aid. But, they're like my husband today. They couldn't go to a committee meeting and feel comfortable. They couldn't go to the pub with their friend to have a beer anymore. So they were staying at home and not socializing. So these are serious problems, but we had no solutions. So then I did a PhD in cognitive psychology to try to figure out, well, what is going on in aging that is not in the ears, that is in the brain, that is in people's social behaviors. And that's been, a few decades of my journey. And here we are. Thankfully, IFA is going to help us to really move forward and work with the 50% of older adults by the time they reach 75 have a hearing problem. So this is a lot of people with a lot of problems that we could work together to do something about.
I would echo many of the things that my colleague Kathy has just said in terms of my trajectory, but it's different. I've been in the field of aging all of my professional career, which is social work. And my first professional job out of graduate school with my master's was in a long-term care facility, and recognized the importance of hearing correction and rehabilitation, as well as vision impairment and rehabilitation, because those two sensory areas, if I may quote Helen Keller, who was born deafblind, said,
My loss of vision separates me from things. My loss of hearing separates me from people. And I would always recognize the importance of our two very critical sensory areas of our vision and our hearing in how we relate to our families, our communities, and society. So went on from the nursing home setting to try and keep people out of the long-term care setting and in their community with just some additional support. And I did that before getting my doctorate. Again, all in social work. But then I really wanted to be on the policy change area. And then my last 24 years of my professional work was for Lighthouse International, which served visually impaired people of all ages, but also recognized the importance of the dual sensory loss. I have a father, had a father, he's deceased now, who was profoundly hearing impaired. Hearing impaired from being around as a farmer, loud machinery, and then due to a medication treatment for his heart condition that saved his life. However, it left him profoundly hearing impaired. And I saw the strain that that put on my mother and on all of us in terms of communicating and how we needed to better control the environment. And then I too am dual sensory impaired. So I now experiencing it firsthand of what that means. So I couldn't be happier that the Decade of Healthy Aging and the work we're doing at the United Nations, which is now my unpaid work at the United Nations, in advocating for older persons' rights, as well as our place within the Sustainable Development Goals and the Decade of Healthy Aging. It really is very important.
Well, I think you've kind of hit on a few excellent reasons why we have to work together. And, you know, the eyes and the ears work together. And when your hearing is not reliable, you know, when it's really noisy, you lip read. And if your vision isn't reliable, you know, you would use your hearing so that you can tell where things are. And then this dual sensory loss that you speak of, which in Canada, according to the Canadian Longitudinal Study on Aging, by the time, you know, very healthy community living older adults, by the time they reach 85, 50% of them have both problems. So yeah. I think those senses work together. But the other thing I just enjoy so much about meeting you is that, you know, we think about ears, you know, as this, you know, thing that hangs off of the side of your head. But you think about the social context and the environment. And I love the international classification of functioning that the WHO has given us so that we can have a framework to see how biological changes actually affect social participation and the importance of environment. So I think these are the pieces that we have to put together is, you know, an audiologist might see somebody in a sound booth. Nobody lives in a sound booth. They go home to their family, they go out to their community, and we just need to go where people live so that according to the healthy aging goal, they can do and be what they value. So we need to put the senses together and we need to get that biological and social continuum working, and we can, it's such exciting times to do that.
Well, it is, and it's very exciting from the point of view, it really is a life course issue. We are talking about a mother who doesn't get good prenatal care or good nutrition, and that baby is at a higher risk and maybe isn't screened like more developed countries have screening for newborn infants to identify whether there's a hearing loss or a vision loss. but many lower and middle income countries don't have such things. And then there's the vaccines and the vaccinations throughout life. And then there are, so that we prevent some of the horrible diseases that had left many people blind or deaf as a result of those illnesses. And so it's this constant life course issue, and the data are there that show from an economic point of view, getting the kind of visual or hearing impairment addressed early and keeping people productive and in their societies, you prevent disability in later life. But I think we have a challenge, Kathy, which is the fact that we have to help people understand there are normal and not normal hearing changes, vision changes that can easily be accommodated over the life course. But there are normal changes. And I think people get complacent, and so do practitioners. And I think the current way we practice medicine in the developed world of sitting in front of a computer, asking the patient questions and not looking at them is one of the biggest hindrances we have. Because I have to ask the practitioner, you must look at me in order for me to hear you better. I can't hear you when your back is to me and you're at the computer. So there's those kind of practical things, but I think that is a real challenge that we have. But the data are there that show in terms of productivity, and I think it's for every dollar you invest in rehabilitation and care, you get a 16-fold increase in productivity and satisfaction of life over the course of, so that just makes economic sense.
Yeah, I think, the economists who have evaluated the investment, if you like, in hearing care, it is the best bargain going. Right. That we can do a lot with relatively little money. It's still expensive in some countries where they don't have public funding. But even at that, compared to other diseases and other possible solutions, it is just the best deal going. And I think we have had a lot of discussion triggered by a Lancet report that was published first in 2017 and then in 2020, showing that hearing, because so many people have it, is actually the greatest potentially modifiable risk factor for dementia. So researchers are working on, can we actually modify it? But there is a huge opportunity to do better. And we've also had the World Health Organization Integrated Care for Older People, the ICO, where vision and hearing are right in there, and cognition and mobility, these other things that rely on the senses, are right there. Right. And I think really when I look at those important works, the ICO and the Lancet, what I see is that hearing is not alone. So many of the other risk factors, diabetes, cardiovascular disease, lack of physical activity, smoking, all of those things are related to dementia, but they are also risk factors for hearing loss. Yeah. So people who get diabetes, they all learn about the risks to their vision, but they almost never learn about the similar risks to their hearing. And the same with cardiovascular disease as a risk factor for hearing loss, like dementia. And then if you flip it the other way, hearing loss puts you at risk for social isolation, which is another risk factor for dementia. So it is a huge soup of risk factors. But I think what you mentioned about, we can do something about it, because hearing loss and vision loss, you get your reading glasses when you're in your 40s, and you start having trouble in the noisy situations in your 40s, but it all happens very slowly. And because it's like your hair goes gray, one hair at a time, you don't notice that. And then one day, it's a problem. And I think that kind of gradual onset makes it a little bit hard for people. People don't just wake up one morning and say, oh, I've got a problem now. It's not like having a fall or something where you have an acute experience. Although in the clinic, if I said to somebody who had hearing loss that needed attention, why did you come in today? What they would tell me is, oh, my sister was dying and I couldn't hear what she said on her deathbed. Or my husband has died and now I have to do the banking. And I need to do that communication and I can't do it. So it was always the social pressures that people couldn't rise to that brought them to the clinic. And it's like, well, we could have gotten to this sooner. And now the WHO World Hearing Report doesn't recommend that hearing screening become part of a typical health check starting around the age of 50, so that people don't have to wait until it's a problem before they are aware of some changes and when they can do things. And, by the time you're 50, what could you do about your hearing? Well, you could be extra motivated to deal with your diabetes and your hypertension. You could eat better. You could exercise, all the things that are good for you anyway. So it kind of fits with the health promotion angle of aging. And then, before you are 40, the kinds of things you could do to prevent hearing loss, noise is a huge one. So this is something where people, I think, are not surprised to hear that noise is going to damage their hearing, but people could do more. And there have been reductions in hearing loss in the population since people started to manage noise. So a lot of the causes of hearing loss are environmental and can be addressed by lifestyle changes. And it's really the same story that rings through many of the healthy aging initiatives. So it could be bundled, and it just could be so powerful together.
Well, thank you. Thank you both for that. And that was a great discussion. We are slowly coming slightly close to the end of the session. But one thing before we do finish off, I want to ask is, let's say we had a crystal ball, one that could show us the future. How would you both say, and how would you both envision the future of hearing health as part of healthy aging?
Well, I'm going to just take this opportunity. The one topic I, scribbled down in my notes that I think we need to say in this discussion is about ageism. And ageism is hugely important. And a lot of the technology of hearing aids and other devices, whether it's an app on your phone these days, whether it's Zoom with captioning, the engineers can make the circuits, but the biggest barrier to getting people on board with looking after their own hearing is stigma. And this is inflated because hearing loss is associated with aging in a negative way. So I think the more we can put hearing care, out of the sound booth into the community, and the more we can have everybody knows what their hearing loss is, it's not a taboo topic, and you don't have to have the courage to raise it with your family doctor because he's just going to test it anyway, like he tests your blood pressure and your glucose. Then destigmatizing hearing loss is going to be part of the campaign against ageism.
I couldn't agree more. And the other part is busting the silos and making sure that we really mean people-centered hearing care, people-centered eye care. as a social worker, it always starts with the person. And what do you want to do? And what's getting in your way? And then ultimately owning our own ageism. We all have our own ageist, tapes that play in our head that we have to overcome. But we can do it, and it's important to do it, which is why I also think there's an opportunity intergenerationally, because we all know this can begin at any age. But I do worry about the very younger generation with only earbuds, listening to very loud music in their ears, or even in cars when they get to drive, the very loud music and what they're doing to their hearing. I fear we could be raising future generations of much more profoundly hearing impaired. And so the other issue is, just as Kathy eloquently said, overcoming ageism, and that's really where it has to start.
Why, thank you both very much, and for your time, for your insights, as well as just the great discussion had today. It really allowed us to kickstart this important conversation and provide a great leeway for our next presentation on what we can do to integrate hearing care into health systems with Dr. Carrie Neiman, as well as Dr. Kathleen Brasher. So thank you both very much.
Thank you.
Thank you.
Thank you both, Kathy and Cynthia, for that. And is there anything that you want to add, or is there anything anyone else kind of wants to add specifically on why we must integrate hearing care into health systems? If there's anyone online who wants to speak, you're more than welcome to raise your hand or any additional thoughts and comments.
Thank you very much for the presentation. I may have raised two questions, but what is really talk about this importance, and of course hearing loss is not just happen now, right? It's already the issue for many years. So my question is more like, so why is it not being integrated? Why is it so ignored? And if any effort that already tried to put that in the system but was denied, and why? Like, what are the challenges? Well, I think, as Kathy said, ageism is alive and well, but I think over the past 20 years, you've seen the implications of the longevity curve increasing. So there are just many more people surviving to later age, and along with it comes hearing impairments, with 50% of the population experiencing it. So I think that and therefore look at the trajectory by 2050 of what's going to happen to that, population. And you're going to see a lot of this. And I think it's just now people becoming aware enough to say, and empowered enough to say, but it's still the average time from when somebody has a hearing impairment or a vision impairment is 7 years before they see corrective measure. Okay. So how do we drill that down? And it has to drill down to primary care, so that your primary care person says, you're not hearing as well as you should. You need to seek intervention. That's where, and I think that's the beauty of what the decade has to offer us, is a vehicle to say, aha, this can't be ignored. It's important to treat it early.
I think that's the importance of screening tools and screening measures, because if you wait for the patients, like for example, Dalia's talk yesterday, if you ask the patients who have objective hearing impairment from audiograms or whatever, and you ask them whether they have hearing problems, maybe like half of them said that they're fine. They don't have any hearing problems at all. And they're practically living their life, and they've never experienced any issue. majority of the time, like for example, when you see older adult walking through the door, you tend to speak a little bit louder because you like subconsciously you are afraid that okay, this person may not be able to hear you. So majority of the time, the older adult can pass by very easily, and they believe that there's nothing wrong with them. Especially like for example in Thailand, older adults are very well respected. So if they misinterpret something you say, you tend to try to like repeat yourself or speak louder to like you don't want to embarrass the older adult, and that's like part of like culture for us. So most of the older adults are hardly aware that they have any problem, or they tend to say that the younger generation is mumbling or like speaking too fast. Like I have a patient who is like lecturer at the university level. She said that all the students these days, they are all mumbling and more of them. That's why I cannot understand when they try to ask questions or whatever. It never occurred to them that it's probably me, because like everyone around them try their best to please them. It's like yeah. So I think that's like, but nowadays, like as you mentioned, it's more like empowered, and then maybe like they receive all the news that okay, probably this can lead to dementia, or like what I see a lot in Thailand is that because the older adults tend to stay with their family members, so they're not staying like by themselves. So they're staying with the family, with the older children and grandchildren. So when the family members heard that okay, this can lead to dementia and it can make grandma have dementia or something like that, they tend to take grandma to the hospital to get the hearing checkup. And that's like actually we campaign towards the middle age and younger generation to take the older parents to come. That's probably we can get more patients that way, because the oldest old, it's very tricky to get to them. Like they're not on social media, they're not reading like newspaper or something like that. So I mean, like that's probably the way. Yeah.
Great.
And I know Kathy actually has her hand raised in the virtual side. Kathy, would you like to unmute?
Yeah, I'm just going to throw out two ideas, and maybe they will evolve over the course of the session. But I think we're in very interesting times. The WHO World Rehab Alliance, they have a working group on interprofessional primary care. And I think all of the rehab professions actually finding a way to work in primary care is going to enable us to enact this screening, and also to make sure that throughout every aspect of healthcare, people can communicate if they have hearing problems. And I'm also very excited because I think it's quite a hot topic now to actually finally integrate accessibility into age-friendly community planning and into dementia-friendly community planning. So I think it's the way we connect that is the moment that we have to seize. So very exciting times.
Thank you, Kathy. And moving along to the next. Moving along to the next presentation, we have Dr. Carrie Neiman and Dr. Brasher for what we can do to integrate hearing care into health systems.
Dr. Carrie Neiman and Dr. Kathleen Brasher for the second presentation on the integration of hearing in health systems symposium on the topic of what we can do to integrate hearing care into health systems. Carrie and Kathleen are leaders in their respective fields, and perhaps to really start this discussion off, can you both please share a little about yourselves, your backgrounds, and how your work and disciplines contributes to the recognition of hearing and other sensory impairments? Maybe, Carrie, would you like to kick the conversation off, and then we can, Kathleen can follow.
Great. No, thank you very much. Yeah, my name is Carrie Neiman. I am an otolaryngologist or an ear, nose, and throat doctor by training, and I specialize as an otologist or an ear surgeon. So a good part of my clinical practice is focused on hearing loss, both from a medical and surgical perspective. And then I spend a lot of my time also in the research realm, bringing kind of a public health perspective to thinking about hearing loss, and particularly trying to address hearing care disparities. So kind of thinking things from the public health perspective as well as from a clinical perspective.
Hi, and I'm Kathleen Brasher. I have a mixed background. I started off as a nurse and midwife. I then fell in love with science and did a science degree, went on to do my PhD, and then took a sidestep into medical anthropology and social theory, which was the basis of my PhD. But really fell in love with the age-friendly cities work when I had the opportunity as a research fellow to take part in the original study that was done in 2006, and was incredibly honoured to be part of the global study of ageing and what makes for an age-friendly city then. And I've continued my involvement with age-friendly cities in various ways, working for advocacy organisations, advising governments of different levels in different parts of the world, which has been extraordinary. I now live in a small rural community and work across a large region in northeast Victoria, both working on age-friendly cities and environments work, but more particularly at the moment working with the health services in how we create both age-friendly health services and also integrated care for older people.
Well, thank you both, Kathleen and Carrie. I think it goes without saying that you guys are just ideal experts for this conversation. And picking up the point on age-friendly, can we integrate that a little with hearing in this context? How, maybe Kathleen, you could first start off, but how would you say age-friendly cities and environments can be more accessible to people who have sensory impairments?
I think it's a really interesting area. It's absolutely essential. We've got a lot to learn from both the existing deaf community and vision impaired community, people who have lived with sensory deficit their whole lives. They have a lot to teach us about what environments they need. And I think we can learn from them, walk alongside and gain from their knowledge and experience, and also respect that they have cultures, they have ways of thinking and ways of working. And our work is particularly with people as we all age, as we're growing older, how our hearing and vision changes, and particularly for this conversation, how our hearing changes and how we can work to create environments where communication, working with and alongside older people, we can actually make sure that the environments that they're living in, they're working in, they're going for their connection to the places and the people around them, how that can be enhanced with I think quite simple steps. And that's what really excites me often about the age-friendly work. It's only small things that we need to do that can make a big difference in people's lives.
Yeah. And I'll just to build off of that, what we know, right, about hearing loss and age-related hearing loss is that it's almost universal. If we look at everybody who's 70 years or older, 2/3 have a clinically significant hearing loss, and everyone who's 80 years or older, it's greater than 80%. And so, we know that there's a large spectrum in terms of, how many individuals have hearing loss, or we will, almost all of us will at some point have hearing loss. And there is then that spectrum in terms of the degrees of hearing loss. And like Kathleen said, there is much to learn from the individuals who have, lived with hearing loss of various degrees kind of their whole life. But then, there's also a large part of the population where hearing loss is, more in the mild to moderate range. And, there are a range of accommodations to be thinking through in terms of, one, I think if you're, thinking about age friendly, kind of the starting point is assuming that the individual in front of you may have some degree of hearing loss. So even just kind of working from that assumption. And then, from there, it's thinking about how do we present information through multiple modalities, and that can go for, kind of the range of sensory kind of impairments and sensory function, so that, you're thinking about, well, if I'm presenting it this way, is the font large enough? Is it loud enough? Are there amplification options available? What types of kind of closed captioning options are available? What kind of visual kind of presentation, and like a range of things of just kind of taking that moment to kind of think through how are we presenting information in the different modes in which we're presenting it. And oftentimes in terms of with advances in technology, there's, it may not be perfect to use, for example, kind of automatic speech recognition in terms of kind of automatic kind of captioning. May not be perfect, but it can often be helpful if the choice is between, that and nothing at all. So with, advances in technology, there's a lot more options there. And I think just kind of the starting point of, yep, if we're talking and thinking about older adults and making it age friendly, sensory impairments need to be up on the list of thinking about how can we kind of make sure everyone has access, and then improve access, for everyone.
I think the other thing I love about captions is that it's often a great sense of humor, because they're not perfect, as you said. And in a way, some of the humor that arises from them is actually a bonding experience. We found that during COVID, because we have our capital city is Canberra, Canberra, and the closed caption misheard it as Ken, K-E-N, Berrin, B-E-R-R-A-N. And so they took the name on as themselves, but that's it. I digress. I think technology does, we can really work with specialists in all sorts of different fields who actually have very good understanding of how sound works and how to create environments, whether they're cafes, public halls, those public spaces where, bus stops and train stations, where people need to be able to get good communication, need to be able to hear each other to make those terrific connections. We can do quite small things with good use of sound and space, and skill and knowledge is out there. And every time I go to say something, I butt up against stigma. The stigma of working in and for older people, the stigma, older people, we hold ourselves about the stereotype of the sort of deaf person with the great big ear horn. And so we need to come into the work. I always think it's that side-by-side work where you don't stand and lecture someone, but you actually stand beside them, and we try to get that understanding. As Carrie said, the numbers are large, and the things that we can do as a community, we're doing it for everyone, and we're doing it for each other and ourselves, our future selves. So it's really important that we recognize that block of attitude is there, even if it's unspoken.
Well, thank you both. And in terms of addressing disparities, what would you say are alternative pathways for hearing care that can address disparities in accessing ear and hearing care related services, specifically for older adults?
I think starting a little bit where we were just kind of talking in terms of, there's a lot of new technologies out there that, like captioning we're talking about, that may not be perfect, but we can't allow perfection to be the enemy of good, in terms of we need to have access to, have a really growing understanding of how fundamental access to information, access to communication, access to kind of visual information in terms of just engaging in our world matters as we age, right? Like that is if we believe in healthy aging, we need to be thinking right alongside that we need to have access to effective communication in the many different forms that it takes. So in order to meet that goal of how do we make sure that everybody has access to that, it's thinking through, okay, not everybody, is going to be able or needs to see an ear, nose, and throat doctor, an audiologist. How can we leverage the many different kind of pathways in terms of thinking through and looking at public health of how do we reach, and partner with different populations? I think there are, a lot of evidence, that exists within public health realms of partnering with individuals like community health workers, peer mentors. And, that is something that has, a lot of power and potential within the hearing care space as well. Just like Kathleen was saying in terms of stigma, there is real power in sharing, some aspect of a lived experience with an individual across from you in terms of thinking about how hearing loss affects an individual, the ways in which they go about, your everyday in terms of managing, communication strategies. How do you get kind of a piece of technology to work? There's a lot there that there's a richness there that is really added, in addition to just thinking about how can we leverage over-the-counter and more accessible forms of technology to help fill those gaps, and not to be afraid of these kind of new and different approaches. Yes, they may not be 100% perfect, but they're pretty good quality. And how can we ensure that that's the highest quality to reach as many people as possible? And those are some of the ways that we can do it in terms of thinking about new, different technology, along with potentially, individuals like myself, NTs, audiologists, to be taking on, in part, a supervisory role in terms of extending our professional reach and our clinical expertise, and then getting that bonus added of that shared live experience from individuals who have some of those same backgrounds and possibilities. So I think that's, in my mind, some of the starting points in terms of thinking about disparities.
I really think that that taking that leadership role from ENT specialists and audiologists is really important. As I said, I live in a small rural community. We have one major regional hospital and one smaller hospital that support a number of quite remote rural hospitals. And I think to address the disparity in whatever form it is, you have to go to the people. You can't sit your hospital or your specialist up on the hill and say, come on up. You absolutely need to be out where people are. And the great thing about hearing care now is that it's portable. A smartphone means you can do an assessment. You can be working with local community groups to say, how do we talk to the people who won't come to this meeting? What do we need to do to help you get out to them? And what can we do to be making sure that our local radios, our local newspapers, our local services are aware of hearing as an issue and how to get information in a way that matters. I think that peer-to-peer with that background support of the specialists is really crucial for working with groups that simply won't come to, people who look like me, white, middle class, educated. It just doesn't make a whole lot of sense. And yet there's a whole lot of people that can do the bridging work, that are connected. And some of those are, one small community I worked with, it was actually the local butcher shop that was the place that we set up the information board. It was the place where the health promotion staff would come, make the connections, be around, because that shop in a small rural community was the one that was there, was warm, was available, whereas the town hall services had moved out into a larger regional setting. The hospital was closing, the general store was closing. So it's really saying what's here, what's working, who are the people that we can work with that connect to people there. And it's not always people with leadership titles, but you've got to hang around enough to make those connections to get a little bit of trust. And then there's the capacity of working with. We've actually taken WHO's ICOPE framework and worked with a large co-design team to turn that around and have it from an older person's perspective. And so we've just got funding now to actually develop up a peer education program using ICOPE in reverse, if you like. So older people being aware of all of these issues, knowing who to turn to, how to get information on them, what they can be doing themselves in their everyday life to make a difference to seeing, hearing, moving and remembering. So, you know, hopefully that'll give us some more ideas.
And I think that is exactly the type of like thinking and approach that we so desperately need and haven't always had, at least within kind of the hearing care and hearing health realms, is that we haven't always thought about community engagement, co-design, and there's just so much power in terms of just asking, just like we will like individuals like myself, you know, yes, I can have my MD, you know, I have all of this classical training and X, Y, or Z, but I will never have kind of that frontline knowledge of one, knowing, you know, that the butcher shop was the place to be, you know, how in the world do we make all of these kinds of guidelines or different recommendations work in the everyday lives of individuals? And I think if we want to have solutions that get at the real problems, we need to bring people along with us who also, you know, yes, they also identify this as an issue and say, yeah, these are the solutions that I think are going to make this work. And we need to be ready and open to actually, you know, not just asking, but listening and taking action in partnership with those individuals as we try to reimagine a way in which we can actually reach more people and deliver care that is responsive, you know, to the needs of the older adults themselves.
And I think some of that is accepting, as you said before, we can't let the perfect get in the way of the good. And I think for us as health professionals, sometimes we want to hold on because we know we can do a better job of assessment, and you know, we will recognize when there are complications that somebody else might. And so that fear of just letting go a little bit is real and genuine, and we need support from our peer group to say, it's okay, let's just test this out and see how it goes. And it's going to feel uncomfortable for all of us. And sometimes I think we really do, you know, we put our capes on, we want to go and save and help. And sometimes the best way of doing that is just to sit back, and it just goes against so much of our training to say, yes, we know the theory, we know that we need to get out, we need to let people, you know, use smartphones to test their hearing, get something over the counter, and let that happen without having done a full assessment, without having, you know, brought someone in to a soundproof booth. So, and I think we need our peers to say to us, that's okay. You're still doing the best job you can do. So it's learning on all sides, I think.
Yeah. And that like the value of none of the disciplines, no one needs to do this alone, right? Like this is the way in which like the magic happens and the new approaches, the new ideas happen, is that, you know, how can we expand access while making it as high quality and as safe as possible, you know, with the different kind of ways in which we're either monitoring or training, or, you know, that we don't have to do it alone.
Yeah.
Well, thanks so much, both. We are slowly coming close to the end of the session, but just before we do, I do want to know if, let's say, we had a crystal ball that could show us the future, how would you both envision the future of hearing health as part of healthy aging?
To me, it's two things have happened. One, we've addressed that stigma of your hearing changing as you age and that you can do something about it. I mean, there's still stigma about putting on some reading glasses or corrective lenses, but people will do that eventually. And yet they seem so, you know, they're quite happy to stick things in their ears to listen to music, but not stick similar things in their ears to hear better. So we will have solved that problem, and we will have this beautiful network of health professionals of all persuasions working collaboratively and collectively to support communities, to support people where they live, to live their best lives in the way they do it, with all of the support we can give them, but that we're the sort of wraparound, but we're there as a network.
And as I kind of look ahead, I would love for sensory health, hearing health, to be truly integrated within how we think about healthy aging, that it's not just this thing set aside, that it's in the domain of specialists, super specialists, that truly is something that is right alongside all of those other things that we're thinking about in terms of aging well, that it's, not just the responsibility of kind of a small specialized group. So those small specialized individuals need to help invite more people into this space, and individuals who may not be used to thinking about hearing, to enter into that space in terms of, we're only going to be able to do this together. And that, yes, we already have new technology, new solutions, new approaches to expand access. And if we look ahead, hopefully there will be only ever more so along those lines. So I think there's a lot of optimism, and we're at a really important turning point in terms of hearing care and hearing health. And I really hope that we take this moment and this opportunity to see where we can bring this together.
For our next session, we have Dr. Kat McComb and Dr. Nancy Swanner on how we will advance integrated person-centered hearing care. And this concludes the first symposium sessions for hearing the later symposium.
Presentation of the first symposium on the integration of hearing and health systems. Today, Nancy and Kat will discuss how we will advance integrated person-centered ear and hearing care. Now, to get this discussion started, Nancy and Kat, can you please both go through your professional backgrounds and how your disciplines contribute to the recognition of sensory impairments as well as healthy aging environments? Kat, would you like to perhaps start off the discussion first?
Yeah, of course. Thank you, Roxana. And thanks also for the opportunity to present at this symposium. I think this is such a great opportunity for us to advance integration of the two fields, which have been largely separate for a long time. So I am a clinical audiologist, and I am currently the head of Department of Linguistics. So we have a number of different programs that sit with under the department, including both audiology and speech pathology. So I do quite a bit around workforce training as well. My research background has shifted quite remarkably over the years. I started looking at animal models of hearing, then moved into really understanding how the brain changes when we provide rehabilitation or a cochlear implant to people who have been long-term deafened. And then when I started working with the World Health Organization, there was a real realization for me about this significant challenge or deficit within the field, which was looking at things from a public health approach. And so my research now is taking a health systems approach to bring ear and hearing care to populations that are least served by our current systems. So the two areas that I've been working, or the two populations that I've been working with, are older adults and also Indigenous Australians, so Aboriginal and Torres Strait Islander people.
Thanks so much, Kat. And Nancy, how about you? Can you tell us a little bit more about your background?
Absolutely. Thank you, Roxana. And Kat, it's an honor to be presenting with you today. I'm a little bit of a unicorn. I did not start out in this space. My background, my degrees are all in education, and my background industry-wise is all in restaurant operations. Education and my background industry-wise is all in restaurant operations. But I currently am the founding director of the Granger Cobb Institute for Senior Living, which is a program that we started at Washington State University in Pullman, Washington, in the United States. in the hospitality school, which is housed in our case in the Carson College of Business. And the programs that we have in the Institute, our goal is really to educate the next generation of leaders that will be out in the seniors housing space. And for us, we define that as age-restricted communities, say 55 and above, independent living, active living, assisted living, and memory care. We stop a bit short of the 24/7 skilled nursing facility, nursing home model, because that's more of a medical model. And what we're talking about is really the value add proposition of socialization and being together in a congregate setting. And so what I focus on more is sort of community operations. And our discussion today will be sort of the science behind hearing and speech and some of those issues. And then I'll throw in a few things about how we can maybe bring those into communities to operationalize them for the betterment of the residents.
Oh, thank you very much for that. And I guess to start that discussion off, can you, in terms of task sharing, can you both describe a little bit how we can optimize communication through task sharing and interprofessional engagement operations to improve ear and hearing care, specifically for older adults as well? Nancy, would you like to perhaps start this one off?
Please. You know, I think operationally, I think one of the things that we have to become better at and much more aware of, especially at the community operations level, is we have residents who are moving in who may not, who are very likely hearing impaired, but may not have ever been actually assessed to know the magnitude of that hearing loss. And that can impact every single thing that happens on a daily basis in a community once they've moved in. And I think that we need to be better or figure out a system for doing some assessments as part of a move-in. You know, in the United States, we're not real great at doing some of those kinds of things upon move-in. And I think if we were to get to that point or be more proactive about that, that then helps us with everything else we do to help enhance resident engagement. Because we know, and it's not just the engagement piece of it, we know the research tells us that people who have hearing impairment are also far more likely to suffer the risk of falling. And that's the last thing we want to happen in our community. So, but on the front end of that, somehow or another, we need to know where those residents are with their hearing capabilities when they move into our communities.
Yeah, that's really interesting, Nancy. It's really become clear over the many years that I've worked in this field that hearing healthcare has sat next to health, but has not been embedded in health. It really has been on the verge in the disability and social sector space. And so the World Report on Hearing, which was launched in 2021, urged all governments or member states to integrate person-centered ear and hearing care into national health plans. And, you know, one of the things that we can ask is how can we integrate hearing assessments into standard health assessments or aging assessments, or as you say, on entry into residential care. I guess the other thing that one of my colleagues was working on, and it strikes me as a really interesting thing to consider as well, is that when we are in difficult conversations or when there's stress around conversations, like, for example, if we're at a GP and we're hearing a medical diagnosis, we tend to take on board only about 10% of what's said. And with a hearing impairment, that significantly reduces the amount that you can access as well. So understanding what people's hearing capability is and optimizing that will certainly increase benefits, not only for hearing what's said in a difficult situation, but increasing the ability for people to connect with others. You know, social connectedness is sort of one of the, and communication is one of the cornerstones of what it means to be human. So if that actually is what we're trying to optimize rather than a focus on device fitting, for example, I think collectively with other professionals we'll do a much better job at reaching that aim.
I would like to add to Kat's comments just one little piece about that, and I don't come at it from the research and science background certainly that she does, but anecdotally from watching my own mother. The one thing about hearing loss is it seems to occur gradually over time. I mean, obviously there are certain things that can happen. You know, people could have a sudden and abrupt hearing loss. But generally, I think it happens fairly slowly over time to the point that sometimes the person themselves doesn't even totally recognize it. And so they may not be super proactive about getting their hearing tested or doing some of those sorts of things. But what happens is as that hearing impairment gets worse, consciously or unconsciously, the person starts to self-isolate. They don't want to be in gatherings. They don't want to be in a one-on-one conversation, especially if there's background noise, because they can't always hear. So rather than be embarrassed or continually say, oh, what, I'm sorry, I didn't hear that, they just choose to not participate. And the real value proposition, as I mentioned earlier, about being in a congregate setting in seniors housing is this socialization piece, because we know that isolation is an absolute killer. And COVID taught us that more than anything. People living in isolation is not healthy. And so if we move someone, or a resident becomes a resident in a community and then still chooses to self-isolate, we haven't probably gained a whole lot. So it is very important that they can hear and participate, to be actively engaged and live purposeful, meaningful lives with a lot of dignity and independence. And that's the foundation of everything around senior living.
And Roxana, to get back to your question about task sharing, there's been a lot of shifts, technological shifts in the field that's really enabled us to get hearing assessments and screening out of the sound booth. And so I think when we look through the lens of what are the opportunities for task sharing, it's the fact that we now have got assessment tools on an on a smartphone. So actually, these really allow other health professionals to be able to screen or assess hearing in a very simple manner, with a sound occluding, so that it reduces the chance of outside or external noises conflicting with the sounds that we're testing. So it enables us to be in a quiet room, to have other health professionals that will be able to test the hearing of older adults. And I think this, it's these things that are the real enablers for task sharing. So we don't have to make an appointment for an audiologist to test hearing within a soundproof room, because all these delays compound so that it becomes very challenging for an individual to do all of the health checks that they need to.
No, thank you very much, both. And how would you say, how can we create age-friendly environments that support rehabilitation for individuals with hearing loss? Kat, would you like to start this one off?
Yeah, thanks, Roxana. So it's interesting that not everybody with a measurable hearing loss will have hearing disabilities or hearing difficulties. And so what that tells us is that the environment, whether it's a physical environment or a social environment, is really enabling, and can, for some people that have got milder forms of hearing loss, can reduce the impact of that hearing loss. And there's been a lot of work around age-friendly cities, and I know Kathleen Brasher was on the previous discussion. These things can reduce the need for devices for everybody as soon as they get the mildest amount of hearing loss. And so if we really consider having spaces which are well carpeted, which can absorb some of the reverberation, these are really enabling. If we have people who understand the impacts of hearing loss, can recognize when people are struggling to hear what's being said and can know how to accommodate that, again, that can reduce the burden of hearing loss for the individual.
And I would add to that at a community level, certainly in the built environment, as Kat alluded to, I think there are a lot of things that can be done as part of either a new build or a remodel that would take into account better acoustics, a variety of things that could be beneficial in this area. I also think, technology-wise, there are a couple of things that also could be helpful. One of the reasons, there's always, well, not always, but there has certainly been a stigma around hearing loss, and it was almost like hearing aids were a bad thing. You didn't want to, they did everything to make them as invisible as possible. And because people didn't want others to know that somehow they had hearing aids. Well, you know what? Apple has now come out with AirPods several years ago, and it made it cool for everybody of every age to have something in their ears. And those are definitely not hidden. They're very much there. But suddenly it became, there was a shift. Now it's sort of okay. It's in fact, you're kind of cool if you've got AirPods hanging there. Well, why can't we take those AirPods and turn those into assistive devices that enhance the hearing ability for someone who has some impairment? I think there's a lot that can be done there, a lot still to be done, but yet now, those are things that are kind of even, sort of over the counter solutions. If we can get some of the testing and assessments done early, as Kat suggested, there may be even be some solutions like, hearing assistive AirPods that don't have to, you don't have to special prescriptions and payments and all kinds of things that really absolutely do delay the process and increase its cost. The other thing, I think at the community level, there are also technologies out there. I think of a company called Eversound that does via a subscription service, does headsets and a microphone and a transmitter and a variety of things that help residents in various activities so that they can hear, so that they can be engaged. Some things have, or you don't have to be on the Wi-Fi necessarily to be able to participate. But the minute people can hear again and be engaged, then they start to live more fully. They start to communicate. They look for opportunities to do events and activities and things that they felt, like as I mentioned, they could have been self-isolating from previously. So there are things out there that both the person who's the resident in a community could be doing on their own, and there are things that communities could be doing, part of a sales pitch, in terms of, look, if you choose to move in with us, we have this technology that allows you to be more fully engaged, whatever it might be. And I think we just need to be better at taking advantage of those kinds of things, because hearing is such a big deal, particularly when it comes to social interaction or lack thereof.
Well, thank you both very much for that. And we are slowly coming close to the end of the discussion. But prior to doing so, the first two presentations actually with Kathy and Cynthia, as well as Carrie and Kathleen, respectively, they ended their presentations with a crystal ball question for what's next. With this context, and in a few sentences, how would you both say the future of aging and hearing care could look like, and especially considering a person-centered approach? Perhaps Nancy,
you want to start that?
Sure, that would be great. Thank you.
I would say the future's pretty bright. I think we've made some advances in the technologies, both in terms of assessing hearing impairment, and then some methods and ways and devices for correcting some of those problems. And I think the stigma around hearing loss is declining. And so I think this notion of a more proactive approach to all of it actually helps quite a bit going forward. And so I see that continuing to roll, and the access to the assessments and the aids ramping up and being easier to get.
I completely agree. I think that if we really are looking forward to what's the outcome we are trying to achieve, then it really is about ensuring that we can support adults to continue having healthy hearing, continue with their social connections into the future. And so looking at it from that perspective, I think that if we can get more into the community so that we don't have barriers of going into the clinic all the time, it enables opportunities for task sharing. It enables opportunities for different devices to be considered. And actually, for as Nancy was talking about, we can look at devices that are more ubiquitous and can be used not only for listening to music, but actually can enhance your hearing in social situations, because the AirPod certainly can do that. It does offer this opportunity to rethink hearing, the importance of hearing, and also rethink how we can enhance hearing, so we can take it out of a medical domain and really looking at it from a social domain. And I think that that's probably the key, because there's lots of things that you could pull in, better acoustics. In the previous symposium, in the previous talks, they were talking about captioning. So lots of enablers, but again, it's to achieve great communication and social connectedness.
Well, thank you very much, Nancy. Sorry, everyone, it seems the video is just lagging and the tech person isn't around to help that, but I'd be happy to forward the PowerPoint after, which has up-to-date or simple voice videos. And I guess following this, is there anyone that wants to add on it, or maybe talk about how this was supposed to be the concluding session?
And when that older person walks in the door, I'm excited by the kinds of things that you're accomplishing in country. But I think it has to begin there. And we've had a disaster in the United States of really integrating oncology geriatric medicine into medical schools. And so it just hasn't really taken off. So unless it's integrated, truly integrated into primary care, and you have to overcome that ageism, then I think it's going to be very hard. So that's where I come out.
And I would like to add that understanding the severity of the hearing loss at the population level is really important, as hearing capacity is at the core of integrated care for older people. I had the opportunity this year as a lecturer in public health to lead the program in the UK, a research program as a primary investigator, understanding for the first time the real prevalence of hearing loss at the population level and the implications for integrated care for older people. And as part of this project, I had the opportunity to interact with 9 place directors who are responsible for 9 local authorities in Cheshire and Merseyside integrated care system in the northern part of England. So having conversations with those place directors, I realized that people are willing to make changes and integrate hearing in integrated care systems, but at the moment they lack the data to do that. All 9 directors told me that they had never seen any data on hearing health before our interaction, which is a shame to my professional opinion, because at the moment we rely on data collected nearly 40 years ago, at least in England, and we count the number of older people in each local authority and roughly estimate a percentage of those who may have hearing loss. This lack of data doesn't put hearing health in the agenda of policy makers. Have, for example, data on vision loss and collect data for vision loss and monitor the changes at the population level for each year and each region in England. And I think that collecting using the existing data from primary care records, as I did in a 6-month project with only a small amount of funding, I think this is feasible and possible so as to raise awareness and add hearing health in the conversation of public health professionals. because resource allocation is being made based on the available data, and there are people who are willing to integrate hearing, but they lack awareness of the problem. That was my.
I think better data is essential, and addressing ageism is essential. And for me, addressing ageism comes through doing small actions on the ground. So using ICOPE as a sort of guiding framework to say that we need, for each older person needs to have a comprehensive care plan that includes hearing in it, so that it's part and parcel of that assessment. But that assessment doesn't need to be done by a specialist. It's an easily used tool at a very low level of training in the health system. So, and in fact, as I described in the video, we're using it in reverse, so that older people will be doing it themselves for themselves. And so that's one way, I think, of integrating it, is to say it needs to be part of your bundle of skills. It's like seeing, you know, we talk a lot about developmental steps of children, and we reach the child's up to this stage. So I think we need to talk about developmental steps for a good later life, and what are those steps you need to take to do that, and to see that as just part of that human development, and having your hearing tested, having your vision tested, keeping physically fit and strong, keeping socially connected, a part of those individual things we can do, and then creating the environment around it that will enable us as the other.
I totally agree that, you know, creating the environment is maybe a very good approach, because if we wait, for example, if you're a primary care provider and then you wait for the patients to walk through your door, maybe that is a little bit too late, as you kindly mentioned earlier, that you may need to wait like 7 to 10 years before the patient actually walks into your door. So probably the better way is to be a bit more like proactive, creating like, you know, the environment that they want to explore within themselves, that, oh, probably I have the problems. So I will share later in my talk later that we host like an exhibition in the center of their communities, and they can, like, you know, bring their friends, their neighbors, and then join this exhibition in their local communities, and then see for themselves whether they probably have hearing problems or not. And like, you know, it's more like a proactive way of doing things. And we also partner up with the community health providers, like, you know, the people who are within the communities, and then they help take care of themselves together. And these people can take like the tablet or mobile phone or whatever application to the patient's home, because if you ask the patients to download the application themselves, they may be like too afraid, like with the technology and everything. So I believe that obviously you have to integrate the, you know, the person-centered ear and hearing care into the system, but it's also a very good touch if we also do more like a proactive approach.
Is there anyone else who would like to discuss a little bit in person, and then we can jump on virtual attendees?
So I just had a couple of comments. I thought it was a really good session. So thank you everyone for presenting. A few things on the chat. I think that you know, the over-the-counter solutions, I think they have a place. I appreciate that you've got to have expert assessment at some point and a diagnosis. But if so many people are not accessing hearing devices, a $300 or $400 solution that they can do their own assessment, and they can have some buds that will provide some hearing correction, will at least give people the opportunity to see what good hearing actually might be like. So it's a bit of an entree really into the fact that someone might have a hearing impairment and how it can be improved, and ultimately seek out, you know, better solutions along the way, because there's certainly some of the over-the-counter solutions are okay, but they're not really, you know, necessarily the best solution for somebody. The other thing too is that certainly in Australia,
there's so many, I think there's a lot of opportunity for people to be introduced to their audiologist a lot earlier. I think that we've got a really good system of optometry in Australia, where you've got Medicare covered. That's our health insurance national program covered for visual assessments, and optometrists are doing more and more in terms of monitoring and diagnosing glaucoma and diabetes and all sorts of issues. So they're playing a much bigger role in eye care. And one very small but important issue in Australia for the common problem of earwax. People go and see their GPs, generally first port of call. You know, the usual scenario is somebody's given cause irritation. And if you wanted to get suction earwax removal, which is the instant solution, you'd have to go to an ENT surgeon, which would normally be a 1 to 3 month wait and a lot of out of pocket. And it's good to see that there are more and more audiologists who are offering that as a solution. And that's another sort of primary care approach that GPs could be using audiologists more. And I mean, the problem at the moment is that service by an audiologist is generally not rebatable. But that's another way that you can get people having a problem, a primary care problem, addressed by audiologists, but it's also an entree into then seeing an audiologist, and they can have a subsequent, hearing assessment, not necessarily at the same time after you've had all that noise of suction in your ears, but I think that integrating audiology more into our primary care system is a way to go.
Thank you very much for that, Chris. And I know.
Well, welcome, Dr. Nancy.
And I know that, Kat, sorry, you got interrupted before because of our internet issues. We're trying to fix it. If you'd like to speak.
Thanks, Chris. I agree. I'll just, from the perspective of having worked as an audiologist, some of the challenges that we have, I think, having audiologists not embedded more within primary care has also meant that when we see older adults to test their hearing and to fit hearing aids, if there is wax in the ears, then there's a finite amount of time when we refer them back to a GP, they come back to see an audiologist, there's quite a lot of cost involved. And these delays can actually mean that they choose not to either go to their GP or not to come back to the audiologist. So I think it's really important to streamline processes and services to ensure that we've got opportunities for to address the concerns at the point of care, if you like. I think the point that was raised about over-the-counter devices, there were a number of professionals that were concerned about that issue for some time. And I think, as Chris has mentioned, the most important thing is to identify and how do we provide information to the general public to identify which devices are high quality devices. And I think that would be a real enabler. I think it's something Kathy was talking about as well. Providing high quality information would enable people to make good decisions and good choices about their hearing health. Thanks, Roxana.
Thank you very much. Is there anything else anyone else wants to add, especially for concluding the first symposium? I'm so sorry about the internet. We are getting a health break now, so please, there's coffee on the side. In that time, we're going to fix the internet hopefully, and thank you very much. But our next discussion is with Ms. Lydia Betts. And this starts off our second symposium of innovation, hearing, and technology. So Lydia is online, and she did also pre-record her session. So hopefully this one does not lag at all. And thank you, everyone.
My name is Lydia Betts, and I am the president of the European Federation of Hard of Hearing People. I would like to discuss today hearing loss and aging, and healthy aging, to be even more precise. So let's take a look at what we can share from our perspective. But first of all, I'd like to share with you what the European Federation of Hard of Hearing is, for those who don't know. We have been founded in 1993 to represent the interests of 57 million hard of hearing Europeans. Our goal is Europe where hard of hearing people can live without barriers and have the opportunity to participate in all levels of society. And we realized our vision through different actions, publications, projects, and campaigns involving our members as well as partners. And the United Nations Convention on the Rights of People with Disabilities, together with EU Social Chapter, serve as a foundation for all our work. And important as well is that we are active member of the World Hearing Forum Alliance, which is aligned with the World Health Organization. So let's talk about the quality of life of people with hearing loss. We look at 4 different areas when we discuss quality of life. One, first of all, is hearing.
We just re-recorded the session. I forgot to do that after.
Quality of hearing care and hearing technology. When hearing loss inclusive policies. We also look at accessible society and equitable treatment. And then we look at strengthening our identity and common goals. And we will discuss more about this. Then we need to discuss as well the numbers. The numbers of people with hearing loss are rising. Right now, over 5% of world's population of 430 million people require rehabilitation to address their disabling hearing loss. And actually its number is higher, 466, when we add children into the quotation. And what is the disabling hearing loss? The disabling hearing loss is defined by the World Health Organization as a 35 decibel hearing loss already registered in the beta ear. And numbers are rising. It's estimated by 2050, over 700 million people, or 1 in 10, will have disabling hearing loss. The figure does not account people who have mild hearing loss, which altogether accounts to 15% of any nation's population, roughly. Let me take you back to what happened when COVID happened and how it affected persons who are deaf or hard of hearing. Now, who are the deaf persons? Those who have acquired speech and have been hearing well and suddenly left or gradually lost most of their hearing. During the COVID-19, we know that all the different services have moved immediately into the telephone support, mostly. They also moved to online platforms, and television has not been accessible to many of us. There was no subtitling, no captioning in many countries. What is important as part of the overview of the systems and the policies at the time is that approximately 1/3 of people over the age of 65 are affected by disabling hearing loss. The figures just shared early on. And this is the group of the people most vulnerable to the virus. Therefore, they needed even further isolation comparing to those who were able maybe to be much more sociable and able to communicate with others. And one of the main impacts of hearing loss on now, when you are only given the access to telephone appointments, telephone consultations, you are actually being excluded if you cannot hear very well. And it's not safe because it can lead to misdiagnosis too. And how actually we communicate and how we interact with public services, banks, medical professionals. First of all, of course, we are using hearing aids or cochlear implants. Then we also use, in collaboration with us, hearing loops or offer assistive listening systems. And when we use all different assistive devices and apps, we use a lot of chats, we use emails, we lip read, and some people use speech to text and sign-supported language. Sign-supported language is mostly for those who actually find it useful, but majority of the people will rely on hearing loops or captioning. So we use visual clues, as we can see, but the policies and systems put in place do not reflect that diversity. And we also deal with attitudes towards hearing loss and stigma. What we see is everyday ageism and negative age stereotype, which does contribute to the stigma. And this is also related to visible characteristics of aging persons, such as hearing aid. Then we also see negative attitudes and language. So, for example, when a person is asking a question, could you please repeat, because they misunderstood what was said. Quite often we hear the next kind of question coming up. Are you deaf or what? But actually this is in a very negative way, but it stops you from asking again, can you please repeat again what you said? And then what we deal with is ever-present ableism. Ableism, which is around society understanding or prejudices of thinking what we can do and cannot do. And often it's part of ignorance, not knowing what solutions are available or how to adapt to a person with hearing loss. Sometimes the adaptations are really simple. It's all about effective communication. So going back to visible characteristic of aging person, let's look at this advert. Hearing aids can be ugly. Ours are invisible. No wonder people don't want to get hearing aids. But then when you look at this photograph, it's actually a photograph of a personal sound amplifier, which is on the stock images quite often produced, and yet it's not actual hearing aid. And no wonder then, but thanks to the report done by Action on Hearing Loss in 2020, we are finding that 41% had to retire early due to impact of the hearing loss and struggles with communication at work, which shouldn't be having situations like that. Yet, remember what we said about rising numbers of people with hearing loss? Well, retirement age is also increasing, and hearing loss is also on the increase. Yet, not enough is being done to improve the situation. We need to come together to change this. And we look at very strong correlation between society attitudes and lack of confidence in linguistic support. So we would like to see reimagined aging and hearing access altogether, make it much more a natural thing to happen. What is the hearing access? It's about allowing people who are deaf or hard of hearing to hear and understand the spoken word and offer audible information clearly. And hearing access is crucial to ensuring equality, diversity, and inclusion for all of us who experience hearing loss. So what needs to happen? What we need to see is national action plans on hearing loss, which need to be developed together with all relevant stakeholders. We need to see inclusive policies in employment, health services, education, etc., which need to be in place, but specifically for older people, employment and health services, to avoid that exclusion of hard of hearing and deaf people that we see right now. And we also need to see accessibility of public places, because it's important to take away that isolation feeling, to ensure that person feels included. And that needs to happen at national and local levels, with public planning services such as hearing loops and captioning provision. But we also need access to affordable hearing aids, quality of hearing care, and very important follow-up rehabilitation, because for many people who are new to hearing loss, actually rehabilitation is allowing them to adjust to the new way of living. So what's part of reimagining aging and hearing loss? We often work with the World Health Organization, especially around the World Hearing Day on the 3rd of March, creating campaigns, creating public lunch debates together with hearing aid manufacturers and hearing care professionals. And we, for example, had this really good part of team in 2019, I think, or 2020, Don't Let Hearing Loss Limit You, where World Health Organization have supported the communications to general, to increase awareness of all different solutions, all different possibilities for people with hearing loss. And this is important because often we do not know about that. Society doesn't know about that, let alone people themselves who are affected by it. So World Health Organization recommends hearing screening for adults over the age of 55. Now remember that 55 is still the working productive age because we are for 10 years in our employment. So we need to build awareness among all the adults and primary healthcare as well of the importance of routine health checks, such as hearing checks. And then we also need awareness about available interventions and what technology is available, what rehabilitation is possible, and communication, which is so vital to the individual, but even more so to the economy, to stop people leaving their jobs when they would still want to be in their jobs. And it is critical that the focus is not just solely on the clinical hearing care. So saying that we provided persons with hearing loss with hearing aids or cochlear implants resolves the problems, resolves the issues. We are fixed? No, we're not. Majority of us still need access, and we still need accessible solutions provided to us, such as creating environments where we can have improved conditioned listening, such as acoustic environments, quieter places, but also hearing loops and captioning as additional support, which helps us to thrive and participate. I think it is important to remember that quality of hearing care is vital for everyone across the lifespan, but especially more for older people. And I'll talk more about it. This is what we want to talk about. Hearing loss and comorbidities. We have been hearing, and I'm sure during the Congress, everybody else hears from different speakers about the importance of dementia and also importance of combating loneliness, etc. So today we want to pick up just on dementia. Various research comes across showing that over 50 million people above 65 years of age have been diagnosed with dementia globally. And that number is expected to triple by 2050 due to the rising number of older people. And then let's look at another side of the coin. Over 60% of all adults diagnosed with dementia will also have a hearing loss, as the research of Nir Masalari et al. Shown in 2017. And then over 90% of adults with dementia who are in social care support will have a hearing loss. Therefore, we cannot ignore this, and we need to work together to push the agenda of quality of hearing care and access to hearing care together. And this is what brings me a little bit of important discussion where we need to talk about barriers to accessing the actual hearing care, such as access to hearing aids. So in 2022, the European Federation has launched another survey to see what is the state of hearing aids provision in Europe. What we have found, especially focusing on adults, that the coverage of a hearing aid reimbursement vary between nothing, 25%, or up to 100% coverage. So some countries do provide hearing aids free as part of national health programs, especially notably Nordic countries. Other countries which have insurance-based system do vary between 25, maybe even 75. Some of them cover nearly 100%. But there are also countries which do not cover really the reimbursement of person with hearing loss who is adult, and some will do it as the means tested way. And in some countries, users need to pay full cost upfront before they can apply for reimbursement later. Additional barrier for the older person. The reimbursement policies do not match the reality, and that is true. We've seen a lot of hurdles with a bureaucratic system and the way the system is developed in some countries. And when we find that children's support is very well established, but when it comes to adults and senior citizens, they often do not receive support, let alone to rehabilitation services related to hearing loss. And we need to change this because Europe has this very important and very ambitious strategy, such as Union of Equality, and it can do so much better than this. But let's not forget, let's go back to the individual we are talking about. A person who is new to hearing loss will face confusing information and advice. And remember, hearing loss is a spectrum and it's not linear. So everybody who you meet might be at different stage and level of the hearing journey. So that's why we say sometimes you meet one person with hearing loss, you don't know really everything about persons with hearing loss. We see wide spectrum of communication tactics, but also we see different challenges and requirements, both at work and leisure time. And that means that not everybody's experience will be the same. What we also see is different range of assistive listening devices, Bluetooth connection, which really can be bewildering to the person who is new to the situation. And there is also a need for digital skills because the technology is actually quite difficult to overcome for some people. And then we see difficulties in receiving quality of hearing care itself, with a good support, with good counseling on managing hearing loss day to day. And what we need to see the organizations for older people, hearing care professionals, and the disabled persons organizations, such as those representing people with hearing loss, to work together. And this brings me to one of the last page, my last slide. We would like to discuss the person-centered approach because it makes sense economically and socially. So once again, we look at prevention of hearing loss and the quality of hearing care that should be part of national action plans on hearing loss across the lifespan. That includes older people. We believe and we know from the practice as well that person-centered approach supports the individual goals and bring the choices, and actually it brings better results for all. Better results in better inclusion, in staying in employment, reducing the isolation, and improve the outcomes for the dementia diagnostics. And when we look at the general personal well-being, but requires multidisciplinary support. It's not just hang somebody's hearing aid on the ears and let them go. This doesn't work. And the communication and consultations between hearing care professionals need to be established between the users, hearing care professionals, as well as the organizations representing us. It's so important to be able to change the policies with one voice And let me bring you with a last quote here from the World Health Organization report on the World Report on Hearing. Harnessing expert knowledge, including hard of hearing representatives, is vital for the implementation of the report. So this is the guidance from the World Health Organizations. Let's work together. Because what we need to make sure, we leave no one behind, and no person who is older is feeling left behind at all. Thank you very much for listening to me, and thank you for your attention. Thank you.
Thank you, Ms. Lydia Best, for sharing your thoughts and your presentation on combating stigma with the use of hearing care assistive devices. So we are actually going to shift the program a little bit, and instead, Doctor, would you like to present? And then after following that, we'll go into Dr. DeVray's presentation, and then a moderated discussion in the end by Dahlia to finish the session.
Okay, so we've talked a lot about like how best we can screen for like population with hearing loss, and then the next step would be what we're gonna do with them. Like, you know, once we know that they have hearing loss, is there like, you know, any technology or any rehabilitation program that is catered for this population? So it's not. Where should I point to?
The middle button. Here, if you want, I can. I'll be your quicker.
Okay.
Just give me a look and I'll go next slide.
Okay, yeah. So first of all, I think like majority of the interest about hearing loss come from the work that, you know, hearing loss maybe give you a higher risk of developing dementia. But the thing is, now we want to know that if you treat hearing loss, dementia risk may be like it can be lower. So that's maybe the key, you know, like it's majority of the dementia risks are non-treatable, but hearing loss is the highest risk factor that is preventable, which means that if you are able to find patients who have hearing loss and you treat them well, the right now tends to shift their focus of finding hearing loss cases, and then like, you know, early detection and early geriatric psychiatry about like if you treat hearing loss, it can prevent your dementia risk. So the work is sponsored by the Alzheimer's Research UK and the National Brain Acute Disease Spread. So next slide. So from the systematic review at UCL, we found that the hearing loss increased the risk of dementia by nearly 2-fold, and that's why right now it's a very hot topic to find and treat hearing loss early. So right now, for example, I just want to make this metaphor. Like before, when we see that, oh, the patient has high blood pressure, nobody wants to do anything because, like, you know, it's just high blood pressure. But now we know, oh, high blood pressure may cause heart problems, brain problems, may cause stroke and other things. So now everyone tries to tackle high blood pressure. Hearing loss is pretty much quite similar. So the previous sessions, we had a discussion, yeah, that the older adult has hearing loss for all their life, and decades ago already that people have hearing loss, but nobody seems to care and nobody seems to do anything about it. But right now we know that hearing loss is the most highest modifiable risk factor for dementia. So now you have to do something about it if you see patients with hearing loss. So it comes to, like, for example, in primary prevention, if you see normal people with normal cognition with hearing loss, we need to also try your best to prevent them from becoming mild cognitive impairment. But if the patient already have mild cognitive impairment with hearing loss, you also need to do secondary prevention before they become dementia. But if you have patients who have dementia with hearing loss, you still need to do tertiary prevention to help them not getting worse. So I will just go through all the intervention that we can do to help each stage of prevention. Yeah. Next slide, please. Okay, so as I mentioned earlier, early detection is key to early intervention. So if you're a normal older adult at age of 15 years or older, you should get your hearing tested no matter whether you have cognitive impairment, dementia or not. If you're just normal older adult at the age of 50, you should get your hearing checked anyway. Yeah, next slide, please. So what we did was that in Thailand, we do not have enough ENT or audiology or like hearing booth or whatever in audiology service. So we have this hearing screening innovation, which is the mobile application. So this is a little bit more advanced than the Hear Who app that WHO is using, because so the project is sponsored by the Royal Academy of Engineering in the UK in partnership with the Thai government. So the application not only uses the Thai wording to detect whether the patient has the hearing loss or not, but it also detect whether the patient can comprehend sound in a spatial directed way. So we have a lot of evidence that patients who have to start to have mild cognitive impairment, they may not be able to tell where the sound is coming from, the sound direction. So this application also can detect that type of, we call it like processing problem. Yeah, next slide, please. So the application was launched earlier this year. It was on the national news of Thailand, and it's also we partner with the private sector as well to launch this app further. So not only that it's free, they can do the hearing screening, not only with the pure tone, beep, beep, and also with the words, with the numbers, and also we have like spatial word recognition test embedded in the application as well. So the patient can know whether they have risk of spatial sound awareness problem, which is also creating a high risk for them to have dementia. So the application is part of the funding that we got under the project Speech Acoustic Virtual Reality Test for detection of early dementia. And it's sponsored by Royal Academy of Engineering, the National Science and Technology Development Agency of Thailand, Program Management Unit of National Competitiveness of Thailand, and our industrial partner, which is Earphone Company. So the application can be downloaded via the iOS and the Android. So this is for the public version, but for the hospital, we also have professionals version. So the professionals version, you can deliver the sound not only through the headphones, but also through different speakers to create the real surrounded spatial virtual realities. So this is already finished for the Thai language, and we are right now apply for fundings to expand to other languages in Thai in the area as well. So the reason that you need to be tested in your local language is quite obvious. Yeah, if you ask the dementia patients to answer some words in English, then they cannot understand the target word well. And also Thai language, similar to Chinese language, is the tonal language, which is different than English version, which means that different tones give different meanings of the word. So that's why if this word come from the different direction and the tone change, the patient may misinterpret the wording, and also that may be a clue that they have a problem with spatial awareness as well. Yeah, so this application we've launched already, and a lot of Thai older adults right now is downloading the application and then test their hearing at home. And the next slide. So I think like a lot of people, like even in the ICO, they mentioned about the mobile application, but not all older adults is comfortable with mobile application. So we have this hearing birdsong exhibition, which is sponsored by the UCL Healthcare Engineering Impact Funding Scheme and the British Council. So the hearing birdsong exhibition is actually, it's originally in the UK. And in the UK, the similar exhibition has been hosted in the older adult community. And we have a similar setting in Thailand, which is the first time outside of the UK. So we launched it at the older adult communities of the Thai Red Cross organization where I work. So I also work at the Thai Red Cross organization as well. It's the communities, in the community, the older adult have their, like, tennis court, swimming pool and everything. So they rarely leave the facility. And we set up this exhibition in the center of the fitness center of the communities. The older adult can just, walk and then try to listen to each bird in this cage. And each cage represents the sound of the bird, which is coincide with the sound that you are testing them with the audiogram. For example, 500 hertz, 1000 hertz, 2000, 4000, 6000 hertz. So the bird songs is on those frequencies. So the older adults love the exhibition. Some of them come and then they're like, oh, they cannot hear this bird, but they can hear those birds. And then they got their neighbors to join the exhibition as well. And the older adult who cannot hear the birds in each cage will get the referrals to get the full-on audiometry testing at the Red Cross organization hospital. So this exhibition was a very huge success, and currently we're hosting the same exhibition in Samyan communities. Today, right now, a lot of my team is taking care of older adult over there. Yeah, next slide, please. Okay, yeah. So this is the some of the how we did the show. So if the patient can hear the bird, they put a sticker on the green area. If they cannot hear the bird, they put a sticker on the red area. Yeah, and then the next one. So it's the funding in collaboration with the hearingbirdsong.com from the UK. So we got like the birds sounds and pictures and everything from the Hearing Bird Song program in collaboration. So I mentioned earlier about the primary prevention, which is the hearing screening for just a normal older adult in the community. Yeah, so this is the project that is done by the Cochlear Center at Johns Hopkins by Professor Franklin team. So it's the RCT that you randomize half of the patients with normal cognition get hearing aid and the other half not hearing aid, and then you follow them up and see if their cognition improved or not. And then the next slide would be about the secondary prevention. So you do similar things for the mild cognitive impairment patients. Half of them get hearing aids, half of them not get hearing aids. So this project, treating hearing loss in people at a high risk of dementia, was the project that I did from my PhD at UCL with Dr. Sergi Costa-Frida and Dr. Doris Barmil. So we found quite a success that patients with mild cognitive impairment with hearing loss, after they get hearing stimulation, they're doing much better. Yeah, next slide, please. And this is for tertiary prevention. So you have already patients who have hearing problems and they already have dementia. Most people will say, oh, there's nothing more you can do about them because they already have dementia. What do you do then? But what you can do is that you can improve their quality of life via the patient-centered care pathway. So what we did was that we learned from the Hopkins Center, so they visited us last year, and then see our dementia daycare center at the Red Cross organization. And then what we did was we tried to improve their communication techniques of the staff and the caregivers and the patients in the dementia daycare center to improve their communication and to see if, we not only give them hearing aids, but these dementia cases need more help than that to kickstart things like not only like, put on hearing aids, but you need to speak a little bit lower rate with them or something like that. So we have also lots of success with the dementia daycare center as well, but we haven't published that yet. So a lot of people is talking about age-related hearing loss, which is that, you cannot hear very well. But what a lot of people is missing is that when the ear is degenerating, the brain is also degenerating as well. So that's what the term called auditory processing problem. So I mentioned earlier that patients who have cognitive impairment or dementia, they may have auditory processing problems on top of sensory neural hearing loss. So next slide, please. So this is auditory processing disorder or problems with the acquired APD. And this is my paper that's published a few years ago that if you test only audiogram on the cognitive impairment and dementia patient, the audiogram cannot tell you the hearing problems that the patient may have. What we did was like we have the Amsterdam inventory of auditory disability questionnaires and the spatial and quality of hearing scale FFQ and the AIAD questionnaires, and then we administer the questionnaire together with audiogram. And then we found that a lot of patients report that they have problems with spatial listening and they have problems with listening in background noise situation. These two problems cannot be picked up by audiograms. So if you test them with audiogram, it says that their hearing is good, it's normal. And the doctor said, no, you're fine, please go back home. But the patient said they still have problems. And the questionnaire, both questionnaires picked up the same problems, and the correlation of both questionnaires is very, very high, which means that it really reflects the problems. So if you see patients who have cognitive impairment, who report hearing problems, audiogram may not be the only thing that you have to test. Maybe you have to do other auditory processing test battery or simply questionnaires. So the next paper of mine is that is there other tests besides the audiogram that can detect the auditory processing problem? So we found that the dichotic digit test can detect the hearing problem. So dichotic digit test means one number on the right ear and the other number on the left ear. So if the patient has the problem in picking up the signal from both ears, they will fail the dichotic digit test. And this test has been also developed on the mobile application that I mentioned earlier as well. So this is like the first time in the world that this test has been on the mobile app. And we found the systematic review that the dichotic digit test can be indicator of hearing problems for patients with dementia. So this work is already published already in the Journal of American Academy of Audiology in 2020. So this was my work a few years ago. Okay, so now we know that we have to do hearing screening with whatever method to get the patients to come to us. And now what we can do with them is the advanced hearing aid and hearing care for the patients with cognitive impairment. So from my experience with these patients with cognitive impairment, dementia, you cannot just only fix them with hearing aids and just let them walk out of the door, because that would not work. And majority of them ended up putting the hearing aids in the drawers and never use the hearing aids again. So for these patients, you know now that they have problem with spatial localization, they have problem with speech in noise. So that is why it's very, very important to fit them with bilateral fitting, with bilateral communication. So the new advanced hearing aids, both hearing aids can also talk to each other via the wireless signals, and this can enhance sound localization and improve speech in noise. The other option for the patients with cognitive impairment is rechargeable hearing aids, because some of the dementia cases, they take out the battery and then eat the batteries because they don't understand. You can also give them the tempered battery door, like the one you give to children, but it may be also good to see if they can use rechargeable hearing aids, but it's also for some cases because, you know, some dementia cases are so afraid of rechargeable things because they're not sure whether the electricity is really in or not, and they're more preferred of the typical battery change. But if that's the case, then you need to always implement safety battery door lock. And the other advanced hearing aid feature that should be given to cognitive impairment patients is the streaming devices like FM system, which can be like, you know, the sound can be connected, the hearing aids can be connected to the TV or the mobile phone. This is to eliminate the background noise, which is like majority of their problems, and help them to understand clear speech, help them to stimulate the conversation to their brain better. Okay, so this is just like why you should give, like, you know, streaming and FM system or the Bluetooth device with the hearing aids with TV and the microphones for the talkers, because otherwise the background noise will just make the dementia patients very confused and not understand the conversation well. This is the position statement of auditory processing disorder of the British Association of Audiology. So all the auditory processing cases should be given remote microphone technology via wireless communication. So I mentioned earlier that, you know, dementia cases, they also have auditory processing problems, so they would benefit the same with the remote microphone wireless technology between the hearing aids and the talker. So the communication partner, the wife and the husband of the patient can wear this microphone, and when they speak, the sound go wirelessly to the patient's hearing aids. It's really help with the understanding and the stimulation of the patient's brain. So the remote microphone can help them not only at the, you know, family dinners or when watching TV or having lunch or, like, you know, what they call, and can also help them to still maintaining their work function. So a lot of our patients who have cognitive impairment, they still go to work. So if in a meeting, if they understand what the other people are saying, it helps them to still maintaining work, and, you know, and those like going out to work also help them maintain their cognition. So this is like one of the examples there. You see that the talker is wearing the microphone clip on the chair, and the sounds go wirelessly to the patient's hearing aid. Another advanced hearing aid technology that can help the patient is the 3D printing of the hearing aid device. So you may see, you know, the traditional hearing aid, which is very big and bulky. But right now, if you do the 3D printing, it means that you make the imprint of the patient's ear and the 3D printing to make the hearing aid into exactly the shape of the patient's ears. So this helps to eliminate, like, you know, the leakage, and also it helps the patient to understand speech better because of the better and proper fit of the hearing aids for the patient. So this type of hearing aids is quite starting to be a standard practice now, to give a 3D printing to get the hearing aid into exactly the shape of the patient. And this is, like, you know, the promise of the future, that maybe in the next 5 or 10 years, the hearing aid will be super smart and can detect whether you want to focus on the person on the left or on the right via the brain EEG and the AI artificial intelligence processing of the patient's brain wave. So we just have the so next slide, please. So actually, I don't have the sessions with Nick Lesica, who was the author of that paper about the future of hearing aid AI. We don't have the session, and we have a very nice discussion now about this. So it should be in maybe 5 or 10 years time.
Thank you very much, Natalie. If anyone has any questions for her, we can definitely address that, but we also still have one presentation by Dr. Leo Vera, and then we can head forth with a moderated discussion, how we take all this forward and what we should really do next. So are there any questions online or in person for the presentation?
I have a question regarding the link between hearing loss and dementia. We have to deal with two conditions that are both highly underdiagnosed and highly stigmatized. And from an epidemiological perspective, I'm still quite skeptical about the link between hearing loss and dementia. I had the opportunity to read a wonderful overview of the current state of knowledge earlier this year by Professor Kathy regarding whether hearing loss modified dementia risk. So what we have done is really wonderful and highly supportive of your work. But I was wondering how you can ensure that linking these applications with the opportunity to prevent the cognitive decline doesn't further perpetuate the stigma of hearing loss.
Okay, so actually I'm speaking about this topic at the Alzheimer's Association conference in the Netherlands in 10 days. If the patients already have mild impairment and they also have hearing loss, and the question is that whether the hearing aid will further stigmatize these patients, yeah? Yes. So we believe that if the patients already have mild impairment or dementia, they are at a very high risk and they're very frail. So it's our job to make the best effort to make them being fully independent and being back into the society. For example, I have a patient who has mild impairment and she does not want to leave the house because she's so afraid that if she leaves the door, she'll get hit by a car because she cannot hear anything. And she's so afraid that she cannot talk to people on the shop or something like that. But after we put on hearing aid, it's like an empowerment for her. So now she have gained her confidence again to get out of the house and everything, and things starts to get better. Because I don't view hearing aids wearing as stigmatization for these patients. Majority of them don't even realize that they have hearing problems. They're just so afraid of leaving the house and they're so frustrated. And once they get empowered by this, hearing amplification, and they get back to like their normal life again, they get out more, they talk to people. It's actually improved their quality of life and all those stigma that I don't see that they have those stigmas, and I think that when their quality of life improves, they're so happy that some of them even said that they should have found this solution a long time ago, or that why nobody has ever mentioned or doing hearing screening for them. So the project I did with Dr. Sergi Costa-Frida in the UK, we went to the patient's home. So we knocked on their door, we did the hearing screening and the hearing intervention inside their house. Because as I mentioned earlier, if we wait and ask the patients to come, maybe they don't want to come. But in this case, with the equipment, I knock on their door. Sometimes they don't even remember that they had the session appointment with me because they have the memory problems. But at least we get the hearing checked, we got the hearing intervention put on with them, and then not only that, we follow them up whether they're successfully and happily using the hearing aid, or they forgot how to change the battery or something like that, and we try to stimulate them to go out and assume their social life activities. So because I think the risk of dementia is actually in the decrease of the social connection with others. So if you have your hearing aids on now, at least you can have built more network and connection with others, and that actually helps quite a lot with dementia in itself, regardless of the hearing improvement.
Yes. Thank you very much for the presentation. So I wonder that when you hearing aid, it's very distracting.
like also the more technology that included, the more expensive it is. So what would be the solution for the more like a low income country or family? And so for example, the one that is reimbursable in Thailand, I think about what you said, it would be like, bare minimum. So it's not like the one I used in the research work in the UK. So those one you can do like Bluetooth connection with the television and the binaural communication or something like that. I think if you have limited budget, it's still better to give the patient hearing aid that is like standard hearing aid, better than not giving them the hearing aid at all. So if the patient still complain of the hearing they don't know where the sound is coming from and they cannot understand the conversation very well, you can try your best to adjust the hearing aid settings to eliminate the background noise. But majority of the patients with dementia will find that the option with the remote microphone really helps. So the caregiver or the husband or the wife wear the remote microphone. It really helps quite a lot. So that is an extra purchase. Yeah, so it's not covered by the reimbursement program. In Thailand, it's the same. In Thailand, so the standard hearing aid, standard hearing aid is reimbursable. So actually, I wrote a very nice article with Carrie Needman, one of the speakers today, about like that. We wrote an article together that in Thailand, the hearing aid is reimbursable and also the hearing screening program is free. But how come not everyone older adult in Thailand is wearing the hearing aid? It's because the problem of the awareness. They don't know that, this is a problem, you have to come. So that's why right now I'm trying to raise the awareness of the patients because I believe that the standard hearing aid is good enough for a lot of patients. So when I talk to many older people in Vietnam, because in Vietnam, both the audio test and the hearing aid is not reimbursable, so we have to pay it out with pocket money. So for many people, they just buy the advantage better, and many also quit after a while because they say that it's better. The noise, noise, then they put on the minute and then the thing that will bother so I think like for Thailand, in order to be reimbursable, you need to also follow up the patient at 1 month, 3 months, 6 months, because if they have the problem and they come back to see you at 1 month, there may be a chance we can adjust the hearing. But if you not offer them any follow-up appointment, they will just put the hearing aid in the bin and then never use it again. So follow-up appointment is very important so that they know that if there's a problem, they can come back to see you and there may be something to do about it.
Well, thank you very much. I think we'll go on to our last presentation of today. And then following that, we'll have a concluding discussion. Because really what we're trying to do is see how we can use all of this for next step. And that's where Valley is doing an incredible job moderating with all of us. So without further ado, I'm bringing up Dr. Derai's presentation regarding the global guidelines and standards of care for adults in hearing loss. Unfortunately, he wasn't able to join for this session virtually. However, he does send his regards.
Hello, everybody. First of all, I would like to thank the organizers to invite me to give a presentation at this beautiful conference on the International Federation of Healthy Aging. I would like to focus in this presentation on the improving of global guidelines and standards of care for adults with hearing loss. First of all, I would like to say that I have no actual or potential conflicts of interest in relation to this presentation. In 2021, so 2 years ago, the WHO launched a very important report, which is called the World Hearing Report. In this report, the WHO asked for much more actions concerning hearing loss because they expect that in 30 years' time, by 2050, the number of people worldwide with hearing loss will be doubled to around 700 million people worldwide. And this is actually the case because, it is especially the case because of the increasing elderly population. WHO wants us to focus on 7 main topics. First of all, we have to focus much more on screening, hearing screening, not only a screening of babies, but also screening of hearing loss in adults and especially in elderly population. We have to focus more on ear diseases, prevention and management. We have to use the current technology. We have very good technology available. We have very good digital hearing aids. We have very good cochlear implants available. So we have to use them. It's not only just using the technology, but also helping the patients to use this technology, which is part of rehabilitation. So we have to focus also much more on rehabilitation and aftercare, so that the technology and the aftercare will have a bigger impact on communication and on their quality of life. We have to take care of noise reduction, especially in the young people, because it also can create some hearing loss or tinnitus at a later stage in life. Last but not least, we also have to take care that the community, those who have a hearing loss, will be involved much more in the rehabilitation and in the aftercare. So, the WHO's first World Hearing Report on hearing, it shows that deafness and hearing loss is a challenging global health issue. It's not only impacting communication, because that's what we hear mostly, is that when you have a hearing loss, you have problems with communication. But communication is influencing your whole life, your whole quality of life. So hearing loss is not only influencing communication, but also your language development, especially in children, but also your cognitive development, your education, your employment, your mental health. So in total, the whole quality of life. It's even, and there's a lot of research going on this topic in the last years, it even has, hearing loss has the largest potentially modifiable risk factor for age-related dementia. And until now, I must say, when you talk about dementia, nobody was thinking about hearing loss. Now it's shown that hearing loss can have really a big impact on dementia. And if you have a hearing loss and you start with hearing aids or cochlear implant early in life, then this can have really a big impact on your cognitive function later in life. So the World Report on Hearing has really shown that a cochlear implant is one of the most successful neural prostheses developed till date, which influence on children enormously. We see now in children that their hearing, their spoken communication, and their educational level, it's much higher than ever before. We also see in adults a huge impact when they use hearing aids or cochlear implant. It improves not only their listening and speech perception, but also their quality of life. So that's the big challenge. We have these good devices. It's shown by the WHO that cochlear implants, hearing aids are very effective. And still knowing this and still having the outcomes of those who are using cochlear implants and who are using hearing aids, they are very, very satisfied. 95% of those who wear cochlear implants are very satisfied. And they say, I should have this cochlear implants much earlier in life. But despite these positive outcomes, there's still a huge underutilization in adults receiving cochlear implant. It's worldwide the case that less than 10% of the adults who are audiologically candidates for cochlear implants are receiving a cochlear implant. You see, Australia is -5%, Belgium around or 5.7%. You even see in Belgium, when I did a research in 2016, and now I did a new research in 2022, the numbers, the percentage has even decreased. It's not that less adults are receiving cochlear implant, but it's because of the selection criteria has changed. In 2016, the selection criteria were what we say above 85 dB. You should have a hearing loss above 85 dB. Now it's 70 dB for a cochlear implant because the outcomes prove that they are, for this severe group, very often better than a normal hearing aids. So in general, we see that these numbers are very, very small. So it's really time to focus on awareness in society, in medical departments, in local ENT doctors, and so on and so on. That's why we started with KICA, which is a cochlear implant international community of action. We started in 2001. And in 2 years' time, we became an international foundation, which is founded in Belgium. We have more than 500 already individuals who are member of KICA, but also 103 organizations, all related with hearing loss, globally, coming from over 60 countries. And we are providing a lot of webinars, KICA conversations, we also call it, and we are developing a lot of resources which you can use if you work on advocacy in your own country. And the first step we were involved in was to come to more international guidelines was the consensus on the impact of unilateral cochlear implants in adults. A consensus paper was published in JAMA Otolaryngology, Head and Neck Surgery in 2020. And this report and this consensus was focusing on 7 topics, focusing on awareness, diagnosis, surgery, clinical effectiveness, post-implantation outcomes, cognitive impact, and cost implications. This was all published in 2020 and was a really good first start focusing on national guidelines. The second step where we are focusing on now, and which is nearly ready, is the development of international living guidelines on cochlear implant. The goal of this initiative is to optimize the standard of care for hearing impaired people worldwide. A first draft was launched the 25th of February this year. This was open for consultation till the end of May, and the final version will be published in July. But these guidelines will be updated all the time as scientific evidence will change, and so also the guidelines will be updated all the time. What we do within these guidelines is that we look at the whole cochlear implant journey, starting from what do we have to do concerning screening, what is the right time to refer to a cochlear implant, to a specialist for a specialist evaluation, what is a good and a standard of care concerning surgery, concerning fitting, and then after receiving the implant and after the fitting, what about rehabilitation? What should be included in rehabilitation and what should be included in lifelong aftercare? All this is done within these the development of these practice guidelines. These practice guidelines are based on 2 things. One is a huge systematic literature. More than or nearly 14,000 publications were reviewed and screened, and over these 151 citations were included. So it's based on scientific evidence. Separate from that, there is a task force developed, a task force, an international task force, of which more than 50 experts from all over the world, and also KICA, so representing users wearing cochlear implants worldwide, were also included in this task force. And all this information from scientific evidence and from the experts is included in the living guidelines. I would like to focus now on a couple of living guidelines, a couple of recommendations coming out. First of all, hearing screening should be offered to adults from the age of 50 worldwide. And this can be done very easily, just by asking the adult or the elderly person, do you feel you have a hearing loss? This is clear that nearly everybody who has problems with their hearing knows it. Most of the time they don't do anything about it, but they know it. So first question is, do you have a hearing loss? Do you think you have a hearing loss? If so, of course, they have to refer it for further checkup to an ENT or to an audiologist. And this screening, it should be done and administered in a frequency of every 1 to 3 years. Of course, in case you have diabetics or kidney dysfunction, or are working in a noisy environment, or if you have tinnitus, or if there is hearing loss in your environment, it's important to check your hearing also already below the age of 50. But the first screening can be done by a primary healthcare practitioner and then referred to an audiologist or an ENT, who can start with fitting hearing aids. And in case there is a hearing loss on 500,000 and 2,000 hertz above 60 dB, and the person also has problems and really difficulties in speech understanding in daily life, wearing their hearing aids, this is a time to refer to cochlear implant. Also, in case there is a unilateral hearing loss above 80 dB, on the 4 frequencies, 500,000, 2,000, and 4,000, it's also time to refer to a cochlear implant. In the last years in the US, they often use what they call the 60-60 referral guideline, meaning if there is a hearing loss above 60 dB, and if the speech perception is below 60%, it's time to refer for cochlear implant and to do really further checkup for cochlear implants. Recommendation number 4, when you receive a cochlear implant, initial activation and programming should take care within the first 28 days after surgery, meaning that in the first year after receiving a cochlear implant, there should be between 4 and 6 appointments. And of these 4 to 6 appointments, 2 or 3 of them should be really in the beginning, in the first 3 months, to start up with the fitting of the cochlear implant. Also, during the fitting, rehabilitation should start, and it's good to have a multidisciplinary team taking care of the rehabilitation, and also to have a multidisciplinary team which really follows a person-centered approach. So it means that the multidisciplinary team should include an ENT doctor, an audiologist, and a speech therapist. But of course, they may also involve other specialities depending on the patient needs. It can be a psychologist or social worker or neurologist, or also peer group support. Last but not least, also it's important to measure outcomes. And 2 outcomes are very important for those who receive cochlear implants. First of all, it's the impact on their quality of life. And the Nijmegen Cochlear Implant Questionnaire is a really good validated questionnaire which can be used. But also, of course, it's important to use validated speech perception tests in the dominant language of the adult cochlear implant user, by using or asking the patients to repeat words or sentences in quiet and in noise. Yeah. And it's good to have these tests done before the implantation and also 6 to 12 months after implantation. So we can conclude that the World Report on Hearing makes clear that deafness and hearing loss is really a challenging global health and social issue. A cochlear implant is one of the most successful of all neural prostheses developed to date. Cochlear implant advocacy is very, very important for adults and especially for elderly people. Yeah. Living guidelines can help. They define the standard of care for adult cochlear implantation. Living guidelines, they were also developed in cooperation with KICA, which is the Cochlear Implant Community of Action and CI users themselves. Yeah. These guidelines will be available from next month, so from July 23, yeah, but they will be updated all the time. Yeah, because new evidence will become available and it will be included in what they call the Magic app, where you can find the living guidelines all the time. Yeah. And you can, of course, adapt them into the needs of your country. So if you want more information concerning these living guidelines, you can find them on the website of Adult Hearing, on the website of KICA. Yeah. And if you have specific questions, please, you can always send them to me. My email is also available here. Thank you very much for your attention, and I wish you a very fruitful conference. Thank you. Bye.
Well, that concludes all our virtual and in-person presentations. But to conclude the session, really, I want to know how we can take everything that we spoke about today, we heard of today, for the future, because that really is the intention. And I have the honor of introducing Dr. Dalia Sampita to help moderate this discussion.
Yes, thank you very much, Roxana. Before we start the discussion, I would like to offer an overview of what we discussed today during the two symposiums. So we all know that hearing loss is a huge challenge, as can negatively impact many aspects of life, not only the hearing ability as widely lived. So communication is affected, the development of speech and language in children, cognition, education, employment, mental health and social life. Starting with the first symposium, we heard two key messages from Sally regarding the integration of hearing care in the health systems as an essential component of universal health coverage and healthy aging. She mentioned that systematic hearing screening is a cost-effective and integral component of person-centered care. The message from Yuka Sumi was that care is an essential domain for increasing capacity and the key factor of social engagement. It is important that hearing is identified as early as possible to maintain the functional ability that enables well-being, the definition of a healthy aging. We have the IFA guidelines available that recommend the crucial domains for increasing capacity and provide a framework and strategies for healthy aging. We have the technical guidelines, the tools provided by WHO, and having all the tools, we can understand why we must integrate hearing care into health systems. We heard insights into what we can do to integrate hearing care and how we will advance integrated person-centered hearing care. Hearing loss is a gradual long-term condition. It is considered a non-communicable disease, and frequently we don't measure hearing as such. And hearing screening needs to be a standard part of a health check, as we heard by Professor Fuller. And Cynthia String mentioned the importance of sensory abilities for full participation in life and healthy aging. As Helen Keller once said, loss of vision separates us from things, but hearing separates us from people. The biggest barrier is stigma, which is something that we need to work, to tackle. And stigma is in place because hearing loss is associated with aging in a negative way. And until recently, it was considered a typical part of the aging process. Regarding what we can do, Kathleen Brasser said that there are several small things we can make a real difference to people's lives in public spaces and having good use of sound in space. Karen Niemann mentioned that we need to make sure that accessible systems are in place for everyone. And to address disparities in access to health services, we need to consider everyday communication strategies and leverage existing accessible forms of technology, such as the over-the-counter hearing aids. To address disparities, which is a really important issue regarding socioeconomic inequalities and barriers in access and use of health services, we need to make sure that the local services are aware of the issues and make a difference in people's lives. At this point, I would like to mention also the important role of medical education. I've been involved in teaching medical students over the past 6 years, and I'm surprised due to the lack of hearing loss as an important part of medical education. Sensory health needs to be truly integrated into health systems and not remain a responsibility of small specialist groups. On how we will advance integrated person-centered hearing care. Professor Kathleen McMahon mentioned and highlighted that the World Report on Hearing urged member countries to integrate person-centered hearing care. And we aim to optimize social connectedness because it is important to implement hearing into the existing systems and play around the existing strengths. Hearing assessment can be an easy and quick process, and task sharing offers a valuable solution. Nancy Songer mentioned that the hearing loss occurs gradually and highlighted the role of hearing impairment and the impact on social isolation. There is a real value proposition in tackling isolation that comes with hearing loss, and this can be, in my opinion, a good link with public health initiatives regarding social isolation and social well-being in later life. Advances in the technology in terms of assessment are provide a tool and we have available assistive devices to reduce stigma. The task sharing can advance integrated person-centered care and can be utilized. In the second symposium, so we've heard the importance of what we can do. And the second symposium was about the leadership in hearing care, starting with the use of ear and hearing care assistive devices. Lydia best approached the topic through 4 lenses: the quality of hearing care and hearing technology, inclusive policies, accessibility, society equality, and strengthening our identity. The key message from Lydia was that investing in person-centered approach is beneficial both economically and socially, and we need to leave no one behind, which is in line with the universal health coverage principles. We have several assistive devices and several tools to communicate, but unfortunately, everyday ageism and negative age stereotypes contribute to stigma around hearing loss. And this stigma is often related to physical characteristics of an old person, such as hearing aids. It is critical that the focus is not only on clinical hearing care, but also creating environments that improve conditions that enable listening and good communication. Also, we heard that the important role of system barriers here in healthcare, as there are at the moment large variations in the state of hearing aid provisions in Europe and system level barriers in addressing hearing loss. So we don't have only the patient, the person barriers, the provider barriers, but also have the system barriers. And there is a hearing loss spectrum, and people are at different stage of hearing journey, which makes things even more complicated. Dr. Nadawan presented recent advances in hearing screening innovations, an application that he developed that detects hearing loss and processing problems in terms of spatial localization. Also mentioned several management strategies with supporting evidence regarding room acoustics, remote microphone system, FM system, customized hearing aids, and with 3D printing. Regarding the potential of hearing loss intervention in mitigating dementia risk, there are some promising advances, and this new application offers the opportunity not only to detect hearing problems, but also to understand issues in spatial localization and issues on how the brain processing sounds abnormally. Finally, Dr. Leo Darib mentioned the guidelines and standards of care for adults with hearing loss, the problem of underutilization of cochlear implants, as less than 10% of adults of those who could benefit from cochlear implants are using one, and presented several recommendations of the living practice guidelines that also tap into the existing guidelines of the WHO on recommendations for implementation of the hearing screening. So we've heard several dimensions of these problems, from personal, provider, and system level approaches. And we discussed potential solutions. We are all aware of this problem, and we are trying to find ways to move things forward, to change the existing situation. I also mentioned the importance of hearing health indicators in health systems. This is a recommendation of the WHO, the World Report on Hearing, and member states need to monitor the problem and address this in public health systems. I would like to ask all participants regarding the potential ideas. What do they think is the most important thing we need to do in the next year, the next 5 years, and in the next 10 years? So I'm starting with you. Would you like to?
I think in the next year, I think establishing that public health link in the database, it's really hard to change government policy without good data and the stories that go with it. So being able to get publicly accessible data that's disaggregated by age and gender and ethnicity and person would really matter.
This is really feasible because the data already exists. We don't need to have funding to design additional studies. All countries that have primary care records, that they are not all countries, but the majority of these have already the data. So we can initiate changes and basically apply the recommendations of the WHO. Would you like to mention what do you think needs to be done in the next year?
I think right now we have the IFA of how best we can do hearing screening for the older adult, but what the main point is that we have to actually implementing that and we have to make it well accepted for the older adults. So co-designing the program that is well accepted by the communities and the older adult probably is the key. Maybe we cannot force off them to use mobile application because they don't like it. So the real life implication is actually harder than what is written on the IFA guidelines. So I think the next year the key priority is implementation, adaptation of the guidelines, and of course designing the patient-centered care for each population, each culture, and each country.
So I think one thing that I think is do next year is to raise awareness of people hearing loss. Thus, it's
not take this as like granted, as like when you get older, and not just take it as a physical issue. It's really to see how it's really the problem of lost information with people, losing all this social support, and yeah, so this, and also like a mental health issue also. Yeah, so I think we change that kind of awareness of every people, of every member of the medical doctors.
And I think it's important that there are group domains mentioned hearing capacity and not hearing loss. So emphasizing the importance of maintaining hearing capacity during the life course is important, and not only focusing on addressing hearing loss at the later stage when it is already too late. Yeah. Yes.
I'm very also interested to hear from folks online on their thoughts of how the fields of hearing and how the fields of experts in the fields of hearing and experts in the field of aging can just join together more easily. We're at a conference on aging right now, and we're here with a hearing session, but what are some other opportunities that we can have to just make sure everyone's at the same table when we're talking about hearing health, and specifically in later life?
I'm not sure who asked that question, but I'm glad they asked it. And I think the time is right that we just start talking to each other, and this is why we had that conversational format, which I really enjoyed, and I learned a lot from all of the conversation. So I hope even today at the meeting that there's a chance for people to talk to each other, and that we'll have more chances. In terms of having good data, I mean, I think we also need some good science, and there needs to be sharing of evidence. And one tendency that worries me is that people have not been trained they haven't had interprofessional education. And there is a tendency for audiologists to get a little too excited and try to, replace neuropsychologists and geriatricians and take on, all of aging single-handedly. But I think, we need to work with the physiotherapists and the geriatricians and the neuropsychologists and the people who have contributions to the entire picture. So I think a first step is to get serious about interprofessional education and actually adhering to evidence-based approaches. And the consumers, I think, will benefit from this because they will get the best quality information, and they will, I think Carrie really said it very well about how putting together our pieces will give the people older adults living with hearing loss, the best shot at it. And I'm quite worried we live in an age of misinformation. And there's a lot of misinformation that happened during COVID, and it's rampant on social media. It's rampant in marketing. And I think there's a lot of confusion and distress and inaccuracies about the connection between hearing loss and dementia. And I think we, as hearing experts, we're very capable of advising on hearing screening. But even the geriatricians do not endorse screening for cognitive problems in people who are asymptomatic. So I think we have to have some diplomacy in terms of our relationships with other professions and respect the decisions they have made about how they screen in their domain, and not run too fast and without consulting with each other and without consulting with the public. So great interprofessional education is the way forward.
And Dr. McMahon, your hand is also up. We would love to hear from you as well.
Thank you, Roxana. Of course, I fully agree with Kathy's point. I think interprofessional education and the way that we work is really important. I do think that one of the biggest and probably quickest wins to integrate opportunities for older adults to have their hearing tested and to be on a pathway to have hearing care managed effectively is by embedding hearing checks into existing life checks. It was interesting having the discussion with Nancy Swanger, who talked about older adults on entry into residential homes have a range of different checks, but don't have the hearing check. And I think that these small things build in opportunities for sustainability, and hearing should be considered within a broader arena of health. And I think this is the greatest opportunity for us to move in that direction. Thank you.
Thank you, and Dr. From the European Federation on Hard of Hearing, we'd love to hear from you, Claire.
Hi, hello. So let me introduce myself. I'm a hard of hearing adult. Have been hard of hearing since childhood. And one thing that I would like to highlight is the importance of autonomy for each and every individual, whether the person is an aging person or a person with a hearing loss or a combination. And I think that we need to really talk about a little bit is how to listen to those people, what they need. And I think that's the only comment I want to still make. Academia is extremely important, and also experience with the work of people in the field, but particularly let's listen to also the ones who are affected. Thank you.
Thank you very much. And how about folks from here? I think one thing that I really enjoyed about this session was just having more of that integration, and even with the like the global cafe style that we had with a hearing expert and an aging expert, it was what I wanted to see of having one another bounce off with each other. Having both the perspectives, I think, builds some of those gaps. And what were, I guess, some things that you hope for in maybe a next session, a next summit even, on having a hearing health based symposium, summit, session, meeting on hearing health and later life. How can we improve that, and what should that look like?
Can I offer some ideas? Since we are trying to highlight the benefits of alcohol approach, I think it would be beneficial to organize a hearing symposium and also inviting people from the other domains of increasing capacity. For example, I'm really surprised in research domain that interventions regarding falls, preventing falls, don't consider hearing. So I think it will be important to tap into the strength of the ARCOP framework to integrate professionals and approaches, and this will raise awareness in everybody.
Absolutely. Ms. Beth, your hand is raised. We would love to hear from you as well.
Okay, lovely. Thank you very much. I would like to say I really enjoyed this panel, and I enjoyed also conversations offside with Kathy. We know Ijeta, we met Ijeta a few times before, so I'm really appreciative of your input in a way of messaging. And actually, this is something that I recently have heard as well. But all that messaging about hearing loss and dementia can actually scare people off from actually doing something about their hearing loss. Thinking I don't want to be tested to find out that I've got a hearing loss, and now, okay, I will get dementia. Or, it's just people get confused. So I really appreciate that. But also, like with my colleagues, about my colleague, it's important that we look at, and same as actually Kathy has mentioned, and Catherine, the multidisciplinary approach of also co-working and supporting each other in the messages as we are going through. Because, for example, earlier in the morning, I was listening to the discussion, for example, about the auto captioning. Now, I am not a native English speaker, so we've seen how the auto captioning picked up what I was saying. And this is important because for hearing people, this is something of amusement. Whereas for people with hearing loss, it's not an amusement. we really are confused, and it's so hard to try to work out what is actually being said. So that's why the quality of support is essential, and ensuring that we make sure that everybody is included in whichever part of their lives they are. But actually, the biggest problem we see is the older people living in the care homes, where it's a complete ignorance sometimes towards people with older people, and the fact that many of them may have a hearing loss, and the care homes are not inclusive, are not providing inclusive recreational time, etc. So we need to look at all of those things and make sure, especially when we go back a little bit earlier, that the people who live longer, work longer, as we are expected to work longer, and yet approaching the situations when we can't carry on because of our hearing loss. Thank you.
Thank you very much. And thank you everyone for joining. I realize we are slightly going above our scheduled time, but thank you. I think all the presentation slides will be shared, and thank you again for joining and for leading this interdisciplinary approach of hearing experts and aging experts joining together. This is something that I'm hoping this session will catalyze in the future as well. So thank you everyone for joining. I know some of the time zones are a little bit difficult and we've had some tech issues. I apologize for that, and have a great rest of the day. Thank you.